and Services. We are going to, before we come out of recess for Senate Bill 132, we're going to stand for the Pledge of Allegiance. So. Pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Thank you very much. I know we've got a busy day today. I know we have a lot of people that want to participate today, but I am going to ask if you're standing to either find a seat or stand in the hallway. The first bill that we're going to be coming out of recess is Senate Bill 132. So if you're not here for 132 and you want to make some space for others, I would ask you to do that, but we can't have people standing in the room. If you have signed up to speak, we will come get you so you don't miss your opportunity to speak, and that's how we're going to proceed with that. So thank you. So we're going to come out of recess on Senate Bill 132, relative health insurance coverage for prosthetics. We have 3 speakers. I'm going to call Jonathan Parker. Did we just throw Jonathan Parker out?
I think so.
Uh-oh. Jonathan?
John Parker?
Yes, we threw you out too soon. Come on in. Come on in. I bet you didn't know you'd be the first one called. I know. Ready to go. So if you could state your name for the record, and yeah, we'd love to welcome.
Yeah, Jonathan Parker. Jonathan Parker. Good to go?
You're good to go.
Awesome.
Yeah, welcome.
So good afternoon. I'm John Parker, and I'm here to speak about the proposed bill to expand coverage for secondary sports-related prosthetic legs to amputees over the age of 18. And I'd like to share my personal experience just to illustrate how critical it is for people like me. And so I began my ski racing career at the age of 7, and by 11, I already won a national competition in Beaver Creek, Colorado. From there, my training became intense, skiing 3 to 4 days a week, attending top training camps, and ultimately earning me a spot at Burke Mountain Academy, one of the top ski academies in the world. I then competed at the Junior Olympics and had my sights set on becoming an Olympic athlete. However, at the age of 15, my dream was cut short by a life-changing accident when I went off into the woods at about 45 miles an hour and went into an oak tree. And so this resulted in the amputation of my lower right leg. And despite this, I didn't give up. So I continued skiing. I actually even made the D1 University of New Hampshire ski team as the first disabled athlete to ever make it. But as time passed, I faced new physical challenges. About 3 years ago, I tweaked my knee while skiing. And so I've had to cut back on skiing specifically. And without access to specialized sports prosthetics, which can obviously cost over $10,000 and is not covered by insurance, I'm forced to put all of my weight on just my one leg, as I have skied in the past but it would obviously be nice to be able to put less weight on that leg to reduce the risk of injury as I'm seeing now. So with that being said, I do believe that without this vital equipment, I can no longer safely participate in my lifelong passion. And so this isn't just about skiing for me, it's about maintaining the physical and mental health. Staying active keeps me motivated, keeps me fit, reduces my risk of injury, illness, and costly medical care. And without this, my health has already started to decline, which has led to more doctor visits and medical expenses. This is not an expense, it's a preventative investment. By providing access to the proper tools, we can prevent expensive complications and long-term health issues. It's comparable to maintaining a car, where skipping regular maintenance, like oil changes, might save us money in the short term, but it ultimately leads to more costly repairs. And so in this case, Covering sport-specific prosthetic is like performing preventative maintenance, where it reduces that risk and long-term cost. So let's also consider the broader impact. Encouraging active lifestyle among amputees has numerous benefits. And so lower healthcare costs, improved mental health, and reduced reliance on medications and hospital visits. Insurance is fundamentally about risk management, and in this case, the proactive approach is the most cost-effective one. The opportunity cost of inaction is significant. For me and many others, losing access to physical activity affects every aspect of our well-being. We aren't asking for luxury or excess. We're asking for the necessary tools to live healthy, fulfilling lives while also reducing long-term medical risks and costs. So in conclusion, I urge you to support this bill and extend coverage to active amputees over the age of 18. By doing so, you'll not only help us maintain our physical and mental health, but also create long-term savings for the healthcare system. Thank you for your time and your consideration.
Great, thank you. Any questions for Mr. Parker? Senator Birdsall.
Thanks for your testimony. Just out of curiosity, so how many prosthetics would you believe that you would need throughout? Because I know at some point they must wear out. So how many do you think a person would require?
Would actually go through?
Yeah.
So I have my daily, everyday leg, and then for a sports-specific leg, that would be pretty rare that I would actually go through that. There's also typically about a 1 to 3 year warranty on prosthetics. So typically I'm not the actual prosthetic company itself. Within usually about a 3-year time span, will cover any sort of issues that are related to it being used correctly.
Thank you.
Yep.
Any other questions? Great, thank you very much.
Yeah, thank you. I appreciate it.
Chris Phillips. Chris, I kicked you out too. Man, I'm sorry about that.
All right, no problem.
I kicked them all out, yes. But we want to hear from you, so welcome.
Thank you very much. So my name is Chris Phillips. I'm from Durham, New Hampshire. I'm kind of speaking on two roles. So, and I've spoken here before as a prosthetist and a business owner. But I'm also a lifelong amputee. So I had a birth defect, and so I've been walking on a prosthesis since I started walking at age 2. I'm 49 years old. I'll be 50 this year. Yeah. And
AARP is here, so.
what's that?
AARP is here, so you may want to talk to
I'll be
him.
getting a mailer soon. So my first legs were made out of wood, and I mean that's really wood and leather, and my feet were made out of rubber, held together with bolts that I broke frequently. And I got my first sort of higher activity prosthesis in college, which was like going from a 1940s Buick to a Ferrari, basically. And that really wasn't even sort of the highest end of what we see today in the field. So one of the things that as a prosthetist, I've been very lucky that I have access to some of these higher end components, to trial and things like that. But my patients don't have access to that. So they have access to sort of an everyday leg, and we try to make that as high as functioning as possible. But when they want to go into things of higher activity or specific things, it's very difficult for them to get approval for these components. One of the things that I think about is with this kind of weather, I love to cross-country ski. So my family and I like to spend time in the North Country and cross-country ski. The prosthesis that I wear for my everyday activities is very stiff. It's like an L. So even though it has some spring to it, when I try to move forward with my ski, the toe moves up and I can't slide forward. So I developed a foot that sort of moves and articulates so that when I ski forward, I'm able to gain ground and make it much smoother. So if I was a normal amputee that has an ACA healthcare plan, they wouldn't pay for that foot, and I would not be able to do that with my family. So I consider myself very lucky that I was able to do that on the side. But when my patients come to me and ask to do something simple like that, we're not able to provide that unless they pay out of pocket. And some of those components can be thousands of dollars. So in my perspective, I just want people in this age range, because this bill is for kind of younger amputees, someone that can get healthcare off the marketplace. So these folks are working people, they're younger people, they're people with families that chase around kids, and we see that. And I want them to be able to have the same opportunities that I have. So as a prosthetist, when I'm telling people about what I do, and then they can't have the same opportunities to do that unless they, save money, pay out of pocket, go try to find other resources. So really it comes down to quality of life and exercise. And we all know how important exercise is. I mean, I'm sure some other people are going to tell you about reduced costs or healthcare costs down the road for exercise and things like that. But it really, to me, is more about quality of life and being able to spend time with your family doing the things that your family does, and to be able to stay with them and do that. And I know that my patients that have been able to get some of these devices have certainly utilized them to the fullest. So I wanted to come at that perspective, and thanks for your time.
Yes, well, thank you. Are there any questions? Senator Prentice.
Thank you very much, Chair. Good morning and great to see you again.
Thanks.
So just prior testimony from Jason Parker, he focused in on the health benefits, the equated this to like if you take good care of your car,
Correct.
you take good care, and then it costs you less to maintain that car over time. And we saw when we did the insurance mandate review on the children's version of this bill that there was some supporting evidence that, said, look, if children are active and not leading, more sedentary lifestyles, because, this barrier for them to ski, to play, just even in, play soccer with, kids in their community, then they're going to lead healthier lifestyles, and things like, diabetes may never, ever come their way. Heart disease, other things that over time could become complicating. So with that being said, in your experience as a prosthetist, have you seen, can you back any of this? I'm not doubting what you
Yes.
said. I believe in it. I've seen an insurance mandate review. Can you provide us with
Yes.
any voice to that?
Yes, yeah. So a good example. So we have a patient. So this bill, similar bill was passed in Maine a couple of years back, right? And so I see patients out of our office in Portsmouth. So we see patients from Maine. And this past year, we fit he's about 35 years old, below knee amputee, traumatic amputee. And we were able to fit him with a running blade. So this is a blade that has no heel. It looks like a giant leaf spring. And we just fit him, I think, about a month ago. I had him running up and down the hall. First time he's run, and able to sprint. And he was back to see my partner last week, and he's lost 12 pounds, and he's running 3 miles several days a week, even in the snow, with this prosthesis. He couldn't do that in his other prosthesis. I can't run, for more than 20 yards in my prosthesis. It's just not built for that. It's built for walking. It's built for comfort. It's built for daily activities. But I would never be able to go out and just run a couple miles for exercise. So, but he's been able to do that with this specific leg. So,
Thank you.
Sure.
Appreciate it.
Sure. And just want to announce, just this, been informed by staff, there are people outside that want to speak on this bill. So I would ask you, if you're not here for this bill, if you could give up your seat. I promise you will get an opportunity to speak if you're not here for this bill. But we've got a space constraint this morning. So thank you for understanding. Senator Birdsall.
Thanks for coming in again. So I asked Jason prior, how how many prosthesis do you think someone would go through, kind of an athletic prosthesis, go through throughout their life? I mean, once you get fitted for your regular one and then
Right.
the sports one.
Yeah, that's definitely a tough question to estimate. But so say a running leg, perhaps. I mean, just specific for running, socket fit, the socket's what goes onto your limb, and that's what, controls the anatomy and is there for comfort. People change, and of course we would hope that people would change if they were exercising, that they would lose weight and things like that. But I would say an average socket should last 2 to 3 years. And then components all have a lifespan, just like the tires on your car. So they do wear out over time. So, a running prosthesis that you're using, several days a week, as long as the fit is comfortable, it should last you 3 to 5 years, I would estimate. So.
Yeah, absolutely.
So, I guess what I'm looking at is, trying to limit the number throughout, because they are extremely expensive.
Sure.
So they would need to be replaced at least every 5 years at a minimum.
I would think that would be, kind of an average thing. I mean, I would think, your typical prosthesis for this age range where you're fairly active is going to be, every 2 to 3 years. So.
And if someone is involved in a number of, is there a prosthesis that can be generally used for pretty much any sport, or?
There are different feet specifically that you can use for multiple sports. They're just more dynamic, so they have bigger curves to provide more spring, but they have heels so you can play tennis, you can do things that are more active. The other thing to think about is that the socket is an expensive part because that's custom made for the patient. You can also have different, just like you change the tires on your car for snow, you can have different attachments that you could put on. So it's not, you don't have to completely replace an entire prosthesis every time. You could have different attachments as well. So that could save you some cost.
And how much are the different?
It can range from, when we say expensive, so if you take a typical below knee amputee or like a running leg, it could still, be under $10,000. It's not something that's hundreds of thousands of dollars or anything like that.
Okay, thank you.
Yeah, you're welcome.
Any other questions? Great, thank you very much.
Thank you very much.
So that's the end of the list. Is there anyone else that would like to speak on Senate Bill 132 that has not? Absolutely, come on up.
I think it was, no, actually, I was here prior to, I was here last meeting.
Okay.
Okay that I speak again?
Yeah, absolutely.
Acceptable? And I think.
I just-
Probably.
Get your name again.
Absolutely. My name is Jason Lala. I am amputee myself as well as a prosthetist.
Oh, you're right. I did see you there. Yep, I got
That's
you.
okay.
I got you.
I must have offended last time.
Yeah, no. You look familiar.
Yeah, no, I just kind of wanted to touch on a few other things, and I think Chris and John did phenomenal jobs of covering this themselves. And I want to thank you guys for giving us the opportunity to speak. Going to some of the questions that you had asked about the components and the lives of the prosthesis. One thing to keep in mind is that the components themselves, most of them have a 2 to 3 year warranty period. So if anything is to fail within those 2 to 3 years, that's going to be replaced without cost. As Chris mentioned, the socket, that's the part, the interface with the body, and that can vary. And that depends on how long somebody has been an amputee. I myself, the socket that I'm wearing is literally at least 6 to 8 years old. I mean, it fits. I'm comfortable. I've been an amputee since 1989, so my body's not changing a lot. I have a biking prosthesis that I use, and I've had that for at least that amount of time as well. So if you have a newer amputee though that is getting into the sport or getting into sports and is in, their body changes a lot more. So there is more changes within the first few years. The other thing that I think was, the average cost of a prosthesis, because that was talked about before as well. And I think I heard a figure of $27,000. And I believe that is relatively high for a whole prosthesis. And some of our figures show that it's closer to a $13,000 range than the $27,000 range. An above knee prosthesis is far more expensive than a below the knee prosthesis. And I think that the numbers that we were talking about, my belief is that in New Hampshire, there's approximately 24,000 individuals living with the amputation. But what you have to keep in mind is, like, these figures are extremely difficult to tease out who would actually be using a prosthesis for an activity, because they include everything from digits to partial feet amputations. So that's going to count. When you look at those numbers, someone can lose their index finger, and that's going to count as someone as an amputee. And just going back to, again, reiterating, reinforcing the whole value of exercise. I mean, one of the things over the years that makes me squirm a little bit is this term medical necessity. Is it medically necessary? We know without question that exercise is a health benefit. We know without question that obesity is a major issue in society today. There's studies that are showing that adults with mobility limitations are 2 times more likely to become obese. Nationally, I believe the figures that I saw was that the cost associated with obesity is $44 billion. Now, granted, that's not in the state of New Hampshire, but the point is that cardiovascular disease, diabetes, all of those things, the progression of disease is, I believe there's a 19% incidence of, if somebody has a part of their foot amputated, that they're going to progress and actually have the rest a more significant lower limb amputation. There are also studies that show close to 50% of people suffering from diabetes will end up losing a second leg. So those people, while they may not be necessarily utilizing an activity-specific prosthesis, if we can get to the population sooner, that as John and Chris pointed out, that have the desire to be more active, I think we have the potential to prevent some of that progression of disease. And I think the health saving costs in that are far more significant than the numbers that I believe that we're talking about with activity-specific prostheses. Even myself, when we were kind of just trying to find people to come and speak, the amount of people that are really currently that I would say would be interested in an activity-specific prosthesis, a lot of our population are older diabetic patients. And so we're trying to prevent the progression of them getting to that point. And I think everything else has been covered by both John and Chris, and I just wanted to thank you for your time and consideration. If there's any questions.
Great, thank you. Any questions? Senator Long.
Thank you, Mr. Chairman. Thank you for your testimony. I'm clear on how younger people, the medical necessity. Would you be of the same opinion for somebody who was 49 or older, that the secondary limb would necessitate a medical issue for them?
Chris, you said you're.
There you go.
Being that I'm 53, I'd say absolutely. Yeah, I mean, it's just as important.
Okay.
Unfortunately, I didn't hear all of Chris's story because I was in the outside, but kind of in the same boat. I'm a prosthetist. I have access to certain things because of my profession that others don't. And the amount of times that people come to me and say, "Hey, I would like to start biking. I would like to start running. What are my options?" And it's most of the time it's cost prohibitive. There are foundations that provide activity-specific prostheses for certain individuals, but a lot of them have mission statements that not everybody really falls into that category. So it makes access extremely difficult.
And follow up if I may. Thank you. So the socket.
Yes.
I mean, I clearly understand when you first start using a secondary,
Yes.
there may be adjustments.
Correct.
I mean, I know of somebody whose socket, she was losing weight, but she was just doing competitions, and so I get that. So out of somebody normally maybe doing 3 miles a day, or what's the weight fluctuation where you would have to replace your socket?
That's a good question. And I've seen some people, they'll lose up to 20 pounds and not have to have the socket replaced. There is ways to kind of manage what we call volume loss through adjustments that as prosthetists we're able to make. There are even systems that allow for adjustability within the socket that also compensate for that volume loss. But I would say usually if you're getting up over 20 pounds, you're
Okay.
really looking at replacing the socket.
So on
Now,
average,
yes, and that also you have to consider if you're talking about someone who's, 130 pounds to begin with versus someone who's 240 pounds to begin with, that's a percentage, and it's a significant difference as far as that percentage of weight loss goes.
so the 3 to 5 year average would still, in your mind, still suffice, even with the socket changes?
For an established, for someone who we would call like a stable
Right.
amputee, I believe so.
Okay, great, thank you.
Senator Pretzel?
Just one last question. So in your experience, when people are fitted with the base piece, are they usually fitted with the piece that could have different attachments, or how does that work? Are they just fitted with a base one?
So great question. Currently, we're not, they make a component, it's considered a coupler that has there's a couple of different options, but the most simple way of describing it is it's a pin that's threaded into this piece that attaches the lower part of this component attaches, we'll say, to the foot, possibly the knee, and the upper part attaches to the socket. Now, in the case of, let's use a veteran, for example, or somebody maybe that's on that has workman's comp, that they may have access to multiple prostheses or components. Knowing that, we may design that initially with this coupler in place to allow us to change that. We don't necessarily do that for our everyday average patients at this point because there's nothing to change it to, if you understand what I mean. Meaning that we know that their insurance company isn't necessarily going to cover a running blade or something like that, so there's really no reason to incorporate that piece oftentimes.
I guess what my thought process is, if we fit them originally with a piece that can be attached, would that save costs down the road?
Potentially, but there's also the other thing you do have to kind of consider is the activity that we're talking about. So for instance, riding a bike, as an above knee amputee, the socket, the interface is, for everyday walking prosthesis, is extremely intimate. It is all the way up into your groin. So riding a bike, you don't necessarily need walking stability because you're sitting on a bike, but what you do want is the range of motion to be able to cycle through a pedal stroke, and you don't want pinching and impingement between the bike seat and the prosthesis in your skin. So in that case, you might be trimming the socket down. So in that case, that socket may not be appropriate for walking on. So again, there's so many little nuances. It potentially could, and it just depends on the activity that we're looking at. The other thing that's worth mentioning is on the positive side of things, one of the things that for years, I think I mentioned this last time, but for years that was a soapbox rant of mine, was a lot of the components used in the industry were not rated to be waterproof, if you will. So that eliminated being able to, even jump into a lake or, like I said, be with your kids in the water go to a pool and have your kids in swim lessons or be able to teach your kids to swim. Nowadays, within, I would say even the last probably 5 years, a lot more of these components. I think enough people listen to me whining and crying about it, but a lot of them are now being rated as being waterproof. So, and that can be an everyday prosthesis that can be used for simple things, like I said, going into the water, maybe not competitive swimming of sorts, but so that allows us that allows amputees a little bit more access to different environments, which is also a positive thing.
Okay, so I guess what you're saying is there are some pieces that could be used as the attachment, but there are others that you can't use, like the biking is a piece in itself.
Right. Yeah. The design of
Okay.
the socket would be potentially different. So you would not be able to interchange, like in my case, take a knee and a foot that's set up for biking and put it on my everyday walking leg.
Okay,
It's not
okay,
really compatible.
thank you.
Thank you very much.
All right. Thank you. Sorry.
That? We're checking the hall really quick. Yeah. You ready?
So if you're not here for the second bill, you want to. You're going to be prepared to help everybody else. Okay? You're going to prepare. Jess, we're going to move your parents. Yeah. Thank you. One second. Yeah, there's some more there. Thank you. Yeah, that's mine.
You're the boss, Sophie. Whenever you say. Senator Rosenwald, you are recognized.
Thank you very much, Mr. Chairman. For the record, I'm Cindy Rosenwald. I have the honor to represent Senate District 13, which is in Nashua. And I'm pleased to introduce Senate Bill 122, making changes to our Medicare Savings Programs, which will help our lowest income seniors afford to pay for Medicare when they turn 65. I'm not going to go deep into the weeds on this because there are other speakers who can give more accurate details. But this program has both income limits and asset limits. Depending on the individual's income, there's assistance paying Part A deductibles, which is hospitals, Part B premiums, which is doctors and outpatient services, out-of-pocket costs, and help paying for prescription drugs. Right now, New Hampshire has about 20,000 people on the Medicare Savings Program, some of whom might also be on Medicaid. So who are these folks? Well, we're talking about people turning 65, possibly on the Medicaid long-term care waiver, the developmental disabilities waiver, maybe aging out of aid to the permanently and totally disabled, or Medicaid expansion, which, as you know, ends when you turn 65. And we typically don't spend a lot of time talking about the Medicare savings programs because Medicare is a federal program. However, our state's Medicaid division administers them. And while there are state dollars involved, Some of the assistance is purely federal funds. We are not drawing down all of the federal funds that are available to us. And in addition, participants' drug costs are reduced because they qualify for the federal low-income drug subsidy. I think it's also helpful to remember that to the extent people stay healthy because they can access care, they are less likely to end up in a nursing home and on Medicaid, which is a far greater cost. Besides that, we know people want to stay in their communities. This bill raises the income limits and removes the asset limits following what our neighboring state of Maine has just done. There are others behind me, yes, who will speak more knowledgeably about this. But the question I want to put to the committee is, as the second most rapidly aging state in the country, if we can't help our low-income seniors pay for their Medicare coverage so they can access health care, what are we even doing here? Thank you. I'm happy to take questions.
Thank you, Senator. Questions from the committee? You did a great job.
Thank you.
Thank you. Mary? Are there other Marys in the room? No.
Thought it was a little bit down the list. Thank you.
Yeah.
So my name is Mary Roberge, and as you can tell, I'm here to testify on behalf of AARP New Hampshire in support of SB 122, which seeks to expand the eligibility for the Medicare Savings Programs, also known as MSPs. AARP New Hampshire is dedicated to advocating for the well-being and financial security of older adults. This bill aligns with our mission by addressing the critical issues of healthcare affordability for low-income seniors as well as disabled individuals. This bill does propose two significant changes. One is to increase the income limits to raise the income eligibility limits for the QMB, which is the Qualified Medicare Beneficiary Program, as well as the SLIMB, which is the Specified Low Income Medicare Beneficiary Program. Okay, excuse me. Okay, and expanding the range of individuals who qualify for these benefits. By increasing the income thresholds, more people will be able to access essential financial assistance. These adjustments will ensure that a greater number of low-income older adults and disabled individuals can receive the support that they need. 2, by removing the resource limit, this bill ensures that individuals who may have modest savings or assets are not disqualified from receiving the support that they need. This change recognizes the importance of allowing older adults to maintain a small financial cushion without jeopardizing their access to health care benefits. Many low-income older adults and disabled individuals in New Hampshire are struggling to meet their monthly expenses, including costs for food, shelter, and health care. The MSPs play a crucial role in alleviating some of this financial burden by covering costs associated with Medicare, such as the annual deductibles, co-payments, and most importantly, the Part B premium. By expanding the eligibility for the MSPs, SB 122 will provide much needed relief for those who are most vulnerable. It will help to ensure that older adults can access the healthcare services they need without having to make impossible choices between paying for medicine or other essential needs. AARP New Hampshire strongly supports SB 122 because it represents a significant step toward improving the financial security and the well-being of low-income older adults as well as disabled individuals in our state. We do ask the Senate Health and Human Services Committee to pass this bill. I want to thank you all for your time and your consideration for listening to what I had to say.
Thank you. Are there any questions? Seeing none, thank you very much.
Thank you, and I do have copies for you.
All right, so next on the list, Lori Raymond, Partnership for Public Health.
Hey there, everybody. Good morning. My name is Lori Raymond. I'm here to testify and support SB 122. Like I said, I work for the Partnership for Public Health, and I have been a Medicare counselor for over 7 years, working at the partnership. So I've been a state certified SHIP. I don't know if anyone here knows what that is, but it's a state health insurance program, and I've been certified to help elderly, low income individuals enroll in plans, apply for Medicare Savings Programs, and also during open enrollment, counsel people on the options that they have in Medicare. So the beneficiaries that I have seen over the years are low income, usually living on their Social Security checks. Some is, as low as $1,000, $1,200 a month. And they can barely even make ends meet with that. So eliminating the asset limit would make a really big difference, because a lot of these people, some of them rent, but some of them have their own homes. And that money that they might have saved might help them pay their taxes for their home so that they can continue to live in the home that they've paid for, as well as if they might have a car for transportation. As we know, in New Hampshire, transportation is a huge barrier for people, and especially elderly people that are, may have an old car that they're trying to keep on the road and still stay independent. So it would really help them with that as well. Every year, Medicare goes up. So this year, Medicare Part B is costing people $185. That's just right off the top that they're going to have to pay unless they're eligible for these Medicare Savings Programs. As well as what we're seeing is deductibles go up as well every year. So the costs continue to go up every single year for Medicare, in addition to, just the confusion on what kind of coverage. So I'm asking you all to please support SB 22 today, and I'm happy to answer any questions you might have. And I also have a copy for you all. Thank you.
Are there any questions? Seeing none, I just want to thank you for what you do. I know that the whole process can be very, very confusing and cumbersome, and so I just appreciate what you do for these folks.
Thank you very much. I appreciate what you all do.
Thank you. Okay, Judith Jones. Welcome.
Welcome. I'm so happy to be before you, Mr. Chairman, members of the committee. My name is Judith Jones, and I work for New Futures, which is a nonpartisan nonprofit that works to solve New Hampshire's problems through policy change. But I'm also here on behalf of the New Hampshire Alliance for Healthy Aging. We lead the coalition that supports individuals in New Hampshire who are aging. I'm grateful to have the opportunity to talk about this bill because it would help keep individuals stable in the community. And we've had some testimony about the high cost individuals are facing? And how would the Medicare Savings Program, expanding eligibility, how would that help? So what I'd like to direct you to, I have some written testimony, but the last page of the testimony is a chart that might make things a little more tangible. So the first page of the chart gives you what are the costs. We've heard about the rising costs of Medicare. And the first page of the chart gives you the dollar figures. What are people actually seeing when we talk about Medicare costs increasing? And the big one that's been named is the Part B premium. And the Part B premium currently $185 a month. You'll see there are deductibles. And the other huge cost of Medicare is a cost share. So there are certain costs on Medicare where Medicare just covers 20%, 80%. So the beneficiary is left with a 20% bill. So what folks have done when they're facing these Medicare costs, there are things you can do. You can purchase a supplemental Medigap policy. The cost of those policies can range from $150 a month, $250. You have health conditions, you're older. I've seen up to $450 a month. The gap policies don't cover the Part B premium. What other people do is they get a Medicare Advantage program, and that's another long discussion. But for now, we could say about the Medicare Advantage programs, none of those programs in New Hampshire pay the Part B premium. So we're looking at folks who want to stay in the home, want to stay stable, and facing economic needs. I think it's fair to say that we're in extraordinary times. So when we look at the cost of Medicare, let's look at the numbers for the Medicare Savings Program. So if you flip the chart over, what you've got are two things. One gives you what are the existing eligibility, financial eligibility limits for the Medicare Savings Program. And you can see that these limits are close to the federal poverty level. And what you see also in that chart, just because we're dealing with federal programs, we have to have a lot of acronyms. And this one has the funniest acronyms I've seen, commonly called Quimby and Slimby. But really, instead of getting into the acronyms, what I tend to focus on with these programs is to try to keep it simple. And what you have is the QMB program. It's a low tier, lower income folks. It pays for all the gaps in Medicare. And then folks with a little more income, the Slimby program, it just pays the Part B premium. So you have MSP programs and different tiers of coverage based on income. And then we have a resource limit. And the resource limit is 9,666 to give a tangible number for a single individual, and I have the numbers for a married individual. So when we look at what the bill would do, how would the bill change these figures? If you look at the next table, the proposal is to increase the income limit for the Quimby program to 185% of the poverty limit, and you have a figure that gives you an idea what is that. And then for the SLMB, to increase that up to 250% of the poverty limit, and to do away with the resource limit. The question I know that you have to answer, that's hard in this year when everything is costly, is whether, are these increases reasonable? And I'm going to help show these increases are reasonable based on what people in New Hampshire are facing and also some cost mitigation for these programs. So first, if we look at what are people in New Hampshire facing? So we're talking about income limits. And we're saying, let's increase those income limits. There's a tool, and it's referenced in my material. It's developed by University of Massachusetts at Boston. It's called the Elder Index. And what you can do is go into this tool and look at any county in the United States and look up what's the cost of living if I'm elderly. And you punch in some figures. So am I single? Am I married? Do I rent? Do I own? How's my health? So what we did is punch in this Elder Index, what is the cost of living in Rockingham, Hillsborough, counties in New Hampshire. So to generalize what we found, the monthly cost of living in New Hampshire for the highly populated counties is over $3,000 a month. And I was doing this for a single individual renting in poor health. If we go out into the more rural, we're just under $3,000 a month. So when we ask, is this a reasonable increase? We'd look at these statistics and say, this is a reasonable increase. When you have to look at the elimination of the resource limit and ask the question, is that reasonable? Is this really reasonable to do in a tight budget year? I think this example would help say, this is really reasonable. So let's say I have worked. If I'm on Medicare, I've worked my whole life. I've paid into Social Security. And I'm 74, and I've managed to save $40,000. That would be significant. But if I'm 74, I know that $40,000 has to last me maybe 20 years. So if my roof goes, if my car goes, if my furnace goes, then I have a problem. What this bill would do is provide a safety net so I can then pay property taxes, repair my roof, stay in my home, and prevent further costs down the road. So let's look at cost mitigation under this program. And there is some cost mitigation. So we know if it's a federal program, we have a 50% federal match, and that federal match is for the QMB program. But if you look under the proposal, the federal match for what's proposed for the SLMB program is 100% federal match. Hardly ever 100% federal match, but you get 100% federal match for that. We're also looking at reduction of some burdens on DHHS. When we look at a program, you don't have to check the resources of an individual. We're reducing some administrative burden. To get a little bit more in the weeds, a little bit technical, but it's a benefit. There's a Medicare drug program called LIS, and it helps pay for gaps if someone's having a hard time on Medicare paying for drugs. It's a federal program, no New Hampshire dollars. So what this program says is you're going to be eligible for this federal drug subsidy if you're enrolled in an MSP program. That's the eligibility criteria. So if we increase eligibility for the MSP program, we automatically increase eligibility for this federal program. There are also studies that show if you're giving this tangible economic benefit to people in the communities, that it spills into economic benefit, not only for the household, but the state and the local communities. And this investment is a seed to start and help keep people safe in the communities and not lengthier costs or higher costs in the future. So for those reasons, giving you a tangible tool to help folks in New Hampshire, saying, if you look at all the factors, is this reasonable at this time? Hope that you would vote for this bill, finding that it is reasonable. I'm happy to answer any questions.
Thank you. Any questions on this?
Thank you.
Thank you very much.
Thank you.
And thank you for this. This is helpful.
Thank you.
It's not ready yet. All right, so we've got David Chorney and Rob Berry.
Let me just grab Rob.
No, I'm getting over it.
That's good.
Yeah, I know. I'm healthy as can be. Yeah,
You must have given it to
I think I did give it to him.
No.
I told him that
Well, that must have been the,
because
you were sitting, he was
he
sitting.
was right next to
on
me.
the other
Yes.
side.
Yes,
Okay, I'm okay with that.
What happened?
I think I got you sick 2
Yeah.
weeks ago. Yeah. I'm healthy now. All right, thank you very much. We digress. We're getting a little punchy here.
That's all right. I needed to get ready. And so good morning, Mr. Chairman and members of the
And it's
committee.
early. Yeah,
We're going to be here all day.
I know we are.
But we'll be with you the whole time.
All right, thank you.
So my name is Rob Berry. I'm General Counsel to the Division of Medicaid. And with me, I have
David Chorney, the state's Deputy Medicaid Director.
So we're here just to provide information about this bill. That'll be a recurring theme for us throughout the day as we're here for information. Another recurring theme is that we're still catching up on fiscal note worksheets. We do have an estimate for this one. So our estimate at this point is it would be 14.5 million in general funds per year to implement this legislation. And with that, there is some nuance here. I'm going to pass it over to David because he understands that quite a bit better than me.
Thanks, Rob. And I think as you heard in the prior testimony, and we also passed out a one pager, but it's there is the higher income group is 100% federal funds. So that's not included in our cost estimate. Our cost estimate is the expansion for the lower income group, which is the qualified Medicare beneficiary, so the QMB. And that is 50% state funds and 50% federal funds. We do think that there are some potential cost savings that we have not quantified yet. I would call them, some of them are future cost savings around. So we do think that one of the benefits to the individuals would be to help defray institutionalization, because they would be able to better fully access their Medicare benefit. And so when or if they become fully Medicaid eligible and they're still in the community, that would be a decrease in cost to avoid institutionalization. And the other potential cost savings would be for individuals that are currently enrolled in Medicaid that would gain access to Medicare or better access to Medicare through one of the Medicare Savings Programs through the expanded eligibility. Medicare would then be the primary payer, and Medicaid would be secondary. So we would have some cost savings where Medicare would be paying instead of Medicaid.
Right, question.
Yes, and I think the institutionalization section popped an interest in me in that if we can prevent that, what are the numbers that we could potentially be looking at with that as far as saving people from being institutionalized?
We have to look into that further. But what we would be looking at would be really the difference between defraying nursing facility care and keeping someone enrolled through one of our waiver programs to get home and community-based care. And there is, I need to double check the metric, but I think it's 75%, 25% in terms of the nursing facility is 75% higher than home community-based care. But
Thank you.
Senator Birdsall.
So when you finally do finish the fiscal note, will that have all of that taken in consideration?
to the extent that we can quantify that cost savings, it will, yes.
Yeah.
And how long before we get that info? Before it gets to finance or after?
But before, if we can quantify it, we'll quantify it before finance.
Thank you.
Senator Long.
Thank you, Mr. Chairman. Ms. Jones mentioned some administrative savings. Is that calculated in some of these savings?
So we do think there would be some administrative savings in that the eligibility staff would no longer have to conduct the resource test for the application, but we would also be increasing the number of potential applications that they would have to process.
Okay.
So they're somewhat offsetting.
Thank you.
Yep.
And just to go back to that $14.5 million, and I think I understood this based on the handout that you gave, that's if we implement the QMB as proposed,
yep,
and the SlimB 120 as proposed, but the SlimB 135 is 100% federally funded. Can we do that without implementing the other ones?
That's something we can certainly look into. We would need CMS approval to do that. And I think the idea behind it would be to just institute the income disregard and remove the asset or resource test on that SlimB 135. The feds call it Qualified Individuals Program. And so we could explore that with CMS, but
So
we'd
we
have to
probably need to get approval
Yep.
from them to alter our plan.
And
Yeah.
we have seen from other, I don't think any other state has taken that approach. Most have taken the approach of instituting an income disregard and removing the asset test on both the QMB and the SLIMB 135 populations. But it's certainly something we could explore. And it would be a way to have it be all 100% federal funds. The key difference for the individual would be that SLIMB 135 just covers the premiums, so they'd still be responsible for the Medicare cost sharing.
Right. Right. Great.
Any other questions?
Great. Thank you.
No problem.
Yeah. And they change, they might hold us hostage. Yeah, we're not gonna give you that unless you do. Right.
All right. Thank you very much. Cheryl Steinberg. Good morning.
Members of the committee. Oh, sorry.
Oh, you just turned it off.
Hey, you need the red button. Yeah, there you go.
There was a red light.
You
I
got
thought the
it.
red light meant it was off.
You'll be a pro by the end of the day. Yeah.
So is this okay like that? Okay.
Yes.
Thank you. Hello, Chairman, members of the committee. My name is Cheryl Steinberg. I'm the Director of the Justice and Aging Project at New Hampshire Legal Assistance, and I'm here today to testify in support of Senate Bill 122. The Justice and Aging Project is a legal project that serves people 60 years of age and older. We provide civil legal assistance to those individuals. In addition to helping people with housing and benefits issues and all those typical kind of what we consider legal services issues, we also have specific focus areas, being long-term care residence rights, financial exploitation, which unfortunately is a huge issue in the state, and also illegal and abusive debt collection practices. And over the past 26 years that I've been at New Hampshire Legal Assistance, I've assisted thousands of older granite staters. And I could tell you many of the people that I've assisted could have greatly benefited from this program, but were otherwise found ineligible due to the income or resource limits. Just last week, I spoke with a woman who lives in subsidized housing. Her only income was Social Security, but she was just over that resource limit, so she wouldn't qualify for the program. And I would tell you, just based on the debt collection work that I do, I could tell you there are so many people that struggle. And I see this, there's a term they call the Medicare cliff for people that are older. And once they lose their regular income and they go on Social Security and their medical costs go up, it's a real problem. So they end up using credit cards to try to make do just for their basic necessities. And then they end up getting sued by these, debt collectors. I mean, and I can't tell you how horrible they feel about it. None of them, no one I've ever talked to said, I don't care that I have this credit. They're like really almost in tears when I talk to them. So it's very stressful situation for them. So I have seen it and it happens. So, I think if they could get this help, it would really make a big difference. One setback could really cause them to, make their whole life kind of go in a spiral. And, we know property taxes are so high now. I mean, even though there is some help with some exemptions and so forth, sometimes it just isn't even enough. So, you've already heard about the significant costs associated with Medicare. And so, I mean, actually myself, I just went on Medicare this past year and I was amazed. It's $185 just for the Part B premium. And then I have a Medigap policy that does help cover all the copays, but that's another $150. So, I mean, you think about a low-income person, I mean, that's like a third of their income if they're on Social Security, so they can't afford that, And then the Medicare Advantage plans, as Judith Jones, I believe, said, I mean, those, even though they could be less money, they have these huge deductibles. So like the resource limit, I think we have now under the current Medicare Savings Program could be gone like very quickly if they had to pay that deductible potentially. I would say, so again, so for people that are homeowners and they maybe have these really high property taxes, which I know mine went way up this past year, they might be choosing between staying in their home or paying for these medical costs that they can't afford. So I think choose to stay in their house usually, and they delay getting care they need. And then we get back to that whole thing about their health getting worse and potentially having to have much more costly care down the future when they have no other choice. So I really do think that this program, I mean, it certainly, in addition to helping the individuals themselves, will help the community because it'll help keep them self-sufficient and healthy and be able to contribute to the community versus having to potentially have to access much more expensive state assistance down the road. And nursing home care is, I mean, we were talking about the difference between nursing home care and home-based care. It's, according to this, there's different estimates, but it's definitely, according to Health and Human Services in one of the most recent reports, more than double the cost of being in a nursing home for Medicaid versus being in the community. So it's a real cost. So we definitely would benefit by letting everybody, trying to help everyone stay healthy and not have to go that route. So I hope that your committee will consider this. I know there's a significant potential out-of-pocket cost up front from the general fund, but I do think there's all these other factors that would help balance that out and make it worth it. Thank you.
Great, thank you. Any questions? Thank you very much.
Okay, you're welcome.
Rebecca Sky. Did I get that right? Did I read that right? Okay. Okay. Oh, yep, you're right. There it is. There you are, Dan. I'm sorry I missed you there.
Oh, that's all right. I'm Dan Wise. I'm Communications Director. It's a part-time position for the New Hampshire Commission on Aging, which is a state-created agency that was created to advise the governor and the general court on issues involving their rapidly growing older population in the state. One of the things that we do every year is a comprehensive annual report on what we see as the priority areas for things that people should be concerned about in this area. And expanding the eligibility for a Medicare Savings Program was among the recommendations that we had in our annual report. And I think we've already heard a lot of testimony about the status of older folks who are eligible for this program. And it is worth pointing out that poverty among the older folks over 65 is among the fastest growing part of the poverty population. Right now, the New Hampshire Fiscal Policy Institute says that the poverty rate for people 65 and older in our state went from 6.2% to nearly 8% between 2019 and 2022. And then there was another measure that is called the Supplemental Poverty Measure done by the U.S. Census Bureau. And it's more accurate because it accounts for more regional differences. And poverty for 65 and older adults went from 14.4% is up to 14.4% for older folks, compared to only 8.4% under that regional measure for adults 18 to 64. This bill, as people have indicated, extends an existing program, and it extends a program that has a federal match, and by eliminating the asset test and increasing the income limits, we're really going to be enabling more folks who really need this kind of help to obtain it. And by eliminating the asset test, we're also reducing the burden somewhat on the HHS folks. And basically, what we're doing is talking about enabling people who really should qualify for this to be able to get it. On the back of our testimony is a chart that shows that it's county by county, and it shows that the participation rate in Medicare savings among people who would be considered qualified is no more than 30%. So there's a lot of people who are very low income, who, for a variety of reasons, whether it's the just that they don't know about the program, and then because the compliance and getting onto this program is difficult, that we're not reaching those people. And I think that the bottom line for this program is if we can get them that kind of that Medicare insurance, we've got more of a chance to keep these people healthy and save money down the road by putting off or reducing long-term care costs. And so, what do you want to add to that?
So my name is Rebecca Sky. I'm the Executive Director for the New Hampshire State Commission on Aging. And I just want to echo what Cheryl Steinberg said about the potential costs of receiving care in the home versus receiving care in a nursing facility for the Medicaid program is about double. New Hampshire Fiscal Policy Institute did do a report a couple years back that has that information, and I'm happy to get that and share that with you. I just wanted to add that in California in 2018, they were considering this very issue about the asset test, and they did a study and looked and what they ascertained from their study is that there would be potentially newly eligible individuals to the program in California, a state with 38 million more people than us, would be a total of 182 people. So they went ahead and got rid of the asset test. And a dozen other states have also eliminated the asset test, including states like Alabama, Arizona, Louisiana, and Mississippi. So thank you for your time today, and happy to answer any questions.
Any questions? No, thank you very much.
And I got exactly the 5 copies of our annual report in color, if you haven't seen it yet.
Great, thank you. So is there any other folks that signed up? Okay.
Could
Oh.
I address your question?
Yes, absolutely.
Thank you. So
One more.
you're not the first person to suggest that we just raise the income limit for the SLIMB 135s because that's all federal funds. But I think it's a perverse incentive because the people who really need our help are the Quimbys. Their income is limited to 100% of the federal poverty level. The SLIMBys have higher income. And so I think if this committee wants to get into the finance aspect of this, maybe you could consider looking at different income thresholds rather than what's proposed in the bill. But I hope that we do not ignore the poorest of the poor who need our help the most. And the other thing I would say about nursing homes is that Medicaid pays for 2/3 of nursing home care in this country. And the actuarial statistic basically is if you go into a nursing home, you are likely to end up on Medicaid within 4.5 months. That's how expensive it is. Even if you have some savings, you are impoverished within 4.5 months. So I think there's a lot to be said for keeping people out of nursing homes. Thank you.
Thank you. Is there anyone else that would like to speak on Senate Bill 122? Nobody out there. All right, we're going to close the hearing. Oh, okay. Yep. All right.
So
Give you that.
the assisted living facility went from 8,000 a month to 10,000. Yeah, they're moving, wants to move. That's in Massachusetts. They found one for 7,000 a month in New Hampshire.
One? Wow. So we got 1, 2, 3, 4, 5, 6, 7, 8.
might want to think about limiting that.
We limit this, just 8 speakers.
Oh, good. All right. You don't need me on this one.
I would probably make an announcement that we have a lot of speakers. Please don't repeat yourselves.
Yeah, okay.
And, don't repeat what other people have said. And don't read your testimonials. Whoa.
Oh, yeah, we're gonna
Yeah.
do that. All right, we were just, yes, please. Yeah, we'll just do 3. Are you all set? All right.
Open the hearing on Senate Bill 244. Welcome back, Senator Rosenwald.
Thank you.
It's nice to have you.
I didn't go far.
All right.
Thank you, Mr. Chair. For the record, I'm Cindy Rosenwald from Senate District 13. I'm happy to introduce to you Senate Bill 244, the New Hampshire Needs Caregivers Act. This bill will make pipeline investments in the healthcare workforce. This is about a bill about building up the healthcare workforce for both the shorter term and the longer term, not just retaining the workforce we have, which, as we all know, is not adequate to meet our demands. This bill makes pipeline investments to help create our future health professionals. Despite putting hundreds of millions of dollars into our healthcare workforce, it's still very difficult to get a doctor's appointment, get a hospital bed or a nursing home bed, get home care, get mental health care, or substance abuse treatment. The lack of an adequate workforce has not only led to increased cost in the system, as providers have had to pay enormous temporary staffing costs, but there are also indications that quality is at risk. For example, the Kaiser Foundation reports that the number of hours nursing home residents received of actual care declined by 9% between 2015 and 2023, with nursing hours down a staggering 21%. So in addition to keeping the workforce we must take action to make sure professionals can work at the top of their scope. And also, we have to interest more students in healthcare careers. Senate Bill 244 does these things. I'm not going into a lot of detail because people behind me, and there's a broad coalition of provider groups who want to speak. But first, I want to point out that this year's version of this bill takes a lot of the onus off DHHS by requiring the department to amend its contract with Bi-State Primary Care's Recruitment Center to take on the responsibility for recruitment and retention. And Bi-State would be able to subcontract with other organizations. Other workforce building programs in the bill include engaging middle and high school students in the health professions, sending health professions students to rural and underserved areas of the state, and that would include a family practice residency in the North Country. It would include mentoring advanced practice nurses to expand their capabilities. Particularly important is adding to the student loan repayment program and that would increase access to primary care. Finally, the bill includes Medicaid rate increases of 3% in each of the next 2 years. And I probably should say that the number I put in here for those Medicaid rate increases is not the number the department gave me. It is a lot smaller. So the committee might want to look at giving the commissioner the ability to target rate increases. This bill does have appropriations to cover all this work, but the fiscal note has not been done. And in any case, we would talk about them in finance after a positive vote on the policy. Happy to answer questions.
Any questions? I have a lot of questions, but I think I'm looking at the list. I think we'll get to them as they move along. Thank you, Senator. We have a lot of people that signed up to speak on this, so I hate to do this, but we're going to limit testimony to 3 minutes in an effort to get out of here this afternoon. I would ask you though, as the testimony goes on, if somebody's already made a point on something and that point has been heard, utilize your time and make another point, or cut your testimony short. So with that, Sophie's going to have a timer for us, and that's how we're going to roll here. But I'm going to first people I'm going to call up here is DHHS, just because Senator Rosenwald did speak specifically about rates and the number that she put in versus the number that was requested by the commissioner. So I got Whitney Hammond, David Chorney, and Rob Berry.
Yes, please. Thank you. I could stand here awkwardly. No, it's fine. So good morning. Again, my name is Rob Berry. I'm General Counsel of the Division of Medicaid. I have with me.
Hi, I'm Whitney Hammond. I'm the Interim Deputy Director for the Division of Public Health Services.
David Chorney, the Deputy Medicaid Director.
So I'll just briefly talk about Senator Rosenwald's point. So we've done the fiscal analysis on the bill. Again, we're catching up with the fiscal notes but we have done an analysis on it. So the way we looked at, I'm only speaking about the Medicaid rate increases here for the moment. So the way the bill is written, it has an across the board 3% rate increase in each of the fiscal years, 26 and 27. We would suggest that we go back to how HB2 in 2023 did it, where it had itemized and kind of targeted the rate increases. We just feel like it's a better way to deal with it. And from the bill as a whole, we estimate that it would, in 2026, it would be about 32.4 million in general funds. 32.4. And in 2027, it'd be 38.9 million in general funds. Now, that balance is the difference between the Medicaid rate increases and what was appropriated. So I think it was around, I think it was around 100 million total cost, and it was about 40 million appropriated, but I have to go back and look at that. But that difference is there. That's the Medicaid rate if you do it an across the board 3%. Mm-hmm. Now, if you target it, you might be able to get more within the range of the 20 million that's actually appropriated. And with that, I'll pass it over to, I guess I'll let Wendy start.
Hello. So I just wanted to acknowledge the importance of this bill and the critical role that healthcare workforce plays in the state of New Hampshire for people's health and wellness, and also for the economy. I want to highlight that the department is doing work, particularly in our rural health and primary care unit in the Division of Public Health, that is very well aligned with what's in the proposed legislation. We do have some pipeline programs. We run the current state loan repayment program, which is being proposed to be expanded in this legislation. We did provide a fiscal note worksheet to just capture the costs that would be associated with expanding that program. And then the legislation says that the Rural Health Primary Care Unit would amend our existing contract with Bi-State Primary Care Association to be able to add a lot of the work into their contract, which was responsive to legislation that was proposed in the 2024 session, where the department testified that there would be a considerable administrative burden to oversee all of that work. And so this new proposal is responsive to that and proposes a hub spoke model. It also, I would acknowledge that the bill calls for significant investment in the department's budget in this area during a fiscally challenging time. The work that's proposed in the bill is very well aligned with our existing workforce efforts in the division, and that it addresses something, that's really important, fundamental to health and wellness. There are additional implications for the department, and I'm not sure if, David, you want to say anything.
I think I just defer to what Rob had mentioned about the Medicaid rates and the increases. I think the only nuance is I think the bill directs a 3% increase and then also has a specific appropriation for opioid providers, which is included in the numbers Rob gave, but separate from the 3% is I think a 2.6 million and in both state fiscal year 26 and then 2.6 million in state fiscal year 27. That would be specific to opioid providers. And so we assume with that appropriation, we would increase rates for opioid providers. We may need some clarification or look for some clarification on the definition of an opioid provider to target those rate increases to the appropriate providers. But it wouldn't be necessarily a 3% increase. It would just be as much as the appropriation allows there. So 2.6 million.
Great. Any questions? So I've got a question with, I think Senator Rosenwald brought this point up when she introduced the bill, in that there is a need, a particular need for primary care services in our most rural parts of the state. I come from the North Country, and there's a huge need up there. And looking at some of the things that she's trying to do with reimbursements and whatnot with that, would it make sense, or is it even legal? I don't even know if this is legal, to rather than a 3% increase across the board, to maybe divide that up geographically, so those in some of the poorer communities are getting the reimbursement increases where they need it. And I think she acknowledged the fact that the rural communities do need it, and I can tell you, I can attest to that. It's different to practicing medicine and healthcare in Colebrook is much different than Bedford. And is there an opportunity to ensure that Colebrook really gets a helping hand because they really need it? Is there a mechanism within our reimbursement model that we can utilize that?
It's certainly something we can look into. Generally, with rates, we like to have parity between the rates similar providers get that are providing similar
parity,
services.
3% in Colebrook, parity is not parity, and 3% in Bedford. That's so.
Yep.
So that would reinforce what you're saying. Parity would look different in this case.
And costs also look different too. And so some of our rate methodologies do look at costs, and then they also look at we have some rates. I'll just use hospitals as an example, but the critical access hospitals have a different rate than non-critical access hospitals, and it accounts for essentially it's in their name, the critical access they provide in their communities to hospital services. And so I think that is something we could certainly look into on like the rural care primary side to see if there is a CMS approvable methodology that we would be able to utilize there.
Yeah.
But I think to Rob's point on the targeted rate increases, that is something, if the legislation was amended to do targeted rate increases, we could take that appropriation and instead of applying it 3% to all providers, target it towards the providers that have a critical need for a rate increase.
Great. Because I think, we're a policy committee, we could pass great policy out of here, but if it doesn't stand a snowball's chance because of the cost, I think it's incumbent on us to ensure that policy makes sense. And if there's ways to make this a little more sporty, we could do that.
Yeah.
Right. Thank you. Any further questions? I'm sorry. Yeah. Great. Thank you. Christine Stoddard and Jim Monahan.
Do I get to go first? Good morning, Mr. Chair, members of the committee. My name is Christine Stoddard, and I represent Bi-State Primary Care Association and the community health centers, actually, in your districts. And I'm also here speaking on behalf of the New Hampshire Healthcare Workforce Coalition. You want it?
Hi, and I'm Jim Monahan with the DuPont Group. As a committee as well, where we work with lots of different provider groups in the Medicaid and healthcare space, but we also, with Christine, share the New Hampshire Healthcare Workforce Coalition.
So in 2018, it was very clear from our members, the community health centers and the area health education centers, the mental health centers, the hospitals, CFI providers, area health education centers, that we were in crisis. New Hampshire does not produce enough clinicians. We don't produce enough healthcare staff to meet the needs of the Granite State, which is why it takes so long to get into an office. And if you're a community health center, you have to take patients, regardless of their ability to pay. You can't turn them away. And so in the areas like Littleton, FQHCs will accept you as a patient, but then you might be waiting 8 weeks to get into see your PCP because we just don't have enough staff. And so more than 50 organizations work together to form this coalition, and we still work together all these years later. And as Whitney said, this bill is in response to the concerns that were raised last year about the burden that the bill would have placed on the state of New Hampshire and also your workforce. And so we changed it to leverage state dollars and also private dollars. So Bi-State operates a recruitment center, and my colleague Stephanie will speak to that later. But rather than the state of New Hampshire having to manage all of these contracts and staff up to manage those contracts, we are happy to do that. We have existing relationships with all of the organizations that are listed in the bill, and we also have the subject matter expertise. And I also want to thank you for all of your support. Since 2018, we've been very successful because you believed in this coalition's work and you believed in the impact that it has had. And we've had a number of Medicaid rate increases, but you also helped us create a certification for community health workers last year, which is such an important workforce, and they work to get people into healthcare and expand access to healthcare. And we couldn't have done that without your support. Your support has also allowed us to collect data on healthcare workforce. Believe it or not, before 2019, we weren't collecting adequate data as a state, and now we can because of this coalition's work and because of your support. So thank you.
Thank you.
Great. Thank you, Senator Rochard. I'm going to primarily focus on the Medicaid components of the bill. I think Christine's done a good job of talking about the first part of the bill, which is talking about privatizing the pipeline process for healthcare, and I think we've got a great dialogue going with the department to get there. I'd only add to what Christine had to say there is that if set up properly, we also believe it will be a mechanism where private funds can come in to invest in the healthcare pipeline, so we're not always dependent on the state government for funding those programs. It is an important part of the growth of the pipeline apparatus. With regard to the Medicaid components of it, I know we had some back and forth with the department to try to figure out what the fiscal might look like on it. There's some difference between the 20 million a year that Senator Rosenwald had included and the 32. And I think we can probably continue to do some work in that space. The 20 million was actually based on Governor Sununu's proposal for 3% across the board rate increase, which you did enact in 2023 with some growth in it. What we'll talk to the department either in this committee or when it gets to the department is what's included in that. Does that include pharmacy and medical devices, or is it just providers? Our emphasis would be that it would be just providers when it came to developing the 3% across the board rate increases. I'd also like to stress that there's a bit, I would say, confusion and disagreement with the department on what we did in 2023. The legislature did pass a 3% across the board rate increase for all providers. And then after that, there was a schedule of additional targeted investments to providers that was developed based upon work we did to say, come back to us with your needs over and above the 3%. We did that again this time with 23 different provider groups, and you will hear from the opioid treatment providers that we still haven't been able to get where the legislature wanted to get to in 2023, which is to get their rates to close to Medicare, so that, and you'll hear that from them. So I would urge the committee not to rush to the concept of giving the department the ability to do targeted rates that for the last 3 budget cycles, this coalition of 55 or so groups have always urged an across the board rate increase, mostly because it's one big healthcare workforce. And if you increase rates for LNAs at Littleton Hospital, then they're not going to go work for Grafton County Nursing Home. What we're trying to do is raise the tide for all boats wherever possible, so that we don't end up in that Hunger Games situation, either, in this room when we're deciding who gets what, or at the department level with contracting. It's been an important principle in the last 3 budget cycles, and I think it's worked pretty well. We've been asked each budget cycle, well, why don't we just leave it to the department or somebody else to target it? And always come back to the proposal that the across-the-board investment in the workforce is a wiser way to proceed.
Great.
So,
Hunger Games, yeah. Thank you.
I used to say Survivor Island, but I think Hunger Games means.
Yeah.
Yeah.
Any questions from the committee? Senator Long.
Yeah, you mentioned the data on healthcare workforce. Do you have?
I think
where
the
can I find that?
The department staff is actually here, but I can send you the link to their website.
That would
I'm
be
happy
great.
to do that.
And how is it recorded?
Collected.
Is it capacity to
It's
what?
through their licenses. So when someone goes to renew their license, they fill out a survey that then informs the department where they're practicing, how long they plan on practicing, those sorts of things. Because what often happens is people are licensed in the state of New Hampshire, but they might not actually practice here. So you can't just look at licenses and say, wow, we don't really have a problem, because those clinicians might live in Vermont and only practice in Vermont. So it's very important that we have that data.
Okay, thank you.
And Senator Long, in addition to that, many of the individual organizations have done their own work. You'll hear later from Maggie Pritchard with the mental health centers. They keep a month-to-month vacancy schedule. They can share that with you. The same is taking place with the developmental disabilities agencies, and I think with some of we can certainly share that with you, so you can see the real challenges that folks are experiencing.
And if I may, I forgot to answer your question about different rates and rural opportunities. So the federally qualified health centers exist in medically underserved areas and rural areas of the state. Their rates are dependent on where they are located. We have, by law, a required set of services. So inherently baked into some Medicaid rates, they do acknowledge where in the state they are and which populations they predominantly serve.
Is that just for the federally qualified health centers?
I can't speak to anyone
Okay.
but them. So I would let other people answer that. And the state loan repayment program, to your point, it benefits people in medically underserved areas and rural areas of the state. We do acknowledge that we are not the only healthcare organizations in need. Hospitals also need nurses. Hospitals in Manchester also need nurses. However, we do not have the capacity or the funding ability to give bonuses to staff to join our workforce. And so the way this bill is designed, it's designed to benefit both both the big hospitals in Manchester and Nashua and the FQHCs in Littleton, because we want to be sure that we're helping every healthcare provider type, not just the ones that Jim and I might represent. It really is a collective effort.
Finally, I conclude by saying that you may recall last year many of you were involved in a very significant increase in Medicaid rates, which was dealt with a decade of flat or declining rates. Part of what we're trying to do here with the 3% is to say it probably makes better business sense for the state and for the providers to know that we're going to do a modest 3% every couple of years rather than waiting every 10 years and trying to show up and find $300 million to stabilize the system. So there's a business case, I think, to be made for both the state and the providers for the predictable rate adjustment. So,
Any other questions? I have one more question for you. So you talk about access. Do you think that expanding the scope of practice of the variety of healthcare providers in our state would help alleviate some of the access that we have to primary care? And for example, optometrists, chiropractors, pharmacists, who may be trained at a higher level, but their scope of practice keeps them much lower and ultimately an underutilized asset.
I think one of the bigger issues, Mr. Chairman, is that we have such limited entry-level staff that clinicians can't even practice up to their current scope. And that is one of the reasons why we wanted to certify community health workers. We also need more LNAs. We need more LNAs so MDs can actually do their work instead of doing the work of an MA. We need the entire continuum of care to be able to operate to their full capacity, and we are not there right now, which is why the programs like the New Hampshire Needs Caregivers are so important, because everyone is hurting for LNAs. It's not just the nursing home, it's not just the FQHCs, we're all hurting.
So manpower is your number one
Yes,
pressure point.
yes,
Yep. Great. Thank you.
thank you.
Stephanie Peg.
You just call it
Stephanie. By state primary care. How's that?
That's great.
Yes,
Thank you.
I can
I
pronounce
do identify as bi-state primary care.
All right.
Thank you very much.
Thank you.
Good morning, Mr. Chairman and committee members. I'm Stephanie Paluca. I'm the Senior Director of Workforce Development and Recruitment with Bi-State Primary Care Association. And we've provided written testimony this morning, and to respect your comments, I won't go through everything in our written testimony. But I did want to speak to what the Recruitment Center does, our longstanding partnership with the state of New Hampshire and many of the partners, and how we fit into this bill. So the Recruitment Center's core function is recruitment of primary care providers. We describe that broadly as family physicians, nurse practitioners, PAs, dentists, mental health and substance use disorder treatment clinicians. And we really, we have a team in our office that actually goes out and tries to recruit these health professionals from their training programs, in-state, out of state, wherever they're hanging out. We're going to try to get in touch with them, see if they're interested in working in New Hampshire, and especially in rural and underserved areas. And we've done this work since 1994. And on the other end, we're really helping the employers in the state filling those critical vacancies that they have for the workforce and making sure that they have a supply of clinicians to consider for the openings that they have. Ultimately, they're the ones that hire them and screen them further, but we want to bring the horse to water and make sure that there's an opportunity there. The Recruitment Center was established in 1994, and I was not quite there at the very beginning, but we just had our 30th anniversary, and I got to celebrate that. And it was really a public-private partnership with the state of New Hampshire that started the Recruitment Center. The state had a grant from the Robert Wood Johnson Foundation to put together an infrastructure for the state that would be needed to support access to primary care services, especially for rural and underserved areas. And given the limited training programs and the anticipated growth in this area, they wanted to have a recruitment center that could provide this clearinghouse function and connect clinicians to communities. We have continued to do that. We have over 700 clinicians that we've helped to recruit, worked with more than 100 communities and practices to help them do their recruitment. And 70% of the clinicians we've recruited have gone to rural and underserved areas. So that works, and they stay. which is nice. So this bill is really important, but it really builds upon the work that we've been doing with the department since 1994. And we have a system in place to within our team right now to operationalize the national marketing and outreach efforts. We have experience and we have a team ready to work on that. We also have public-private partnerships that we've done with many of the organizations that are mentioned in the bill. We've also administered a $6 million loan repayment program with for Northeast Delta Dental to get dentists in New Hampshire, Maine, and Vermont, which is their service area, loan repayment to work with rural and underserved populations. We developed with Harvard School of Dental Medicine a new dental residency program for New Hampshire, where 3 dentists come and do training in New Hampshire in rural sites after they're in a postgraduate opportunity 1-year program. We connected Harvard with the community sites, and then we stay in touch with the residents while they're here so that we can recruit them. So we're looking forward to this work. We request that you pass this bill. It's really what is needed for our workforce for today and for the future. Thank you.
Thank you. Any questions? Thank you very much.
Thank you.
Dr. Bill Gessner. Okay. Bill Gessner, and then Sergio Zulik is next. Actually, I don't know if they're going to present together. They're both from.
Could do it together.
Yeah, could we get Sergio and Dr. Gessner? Excuse me. And after that, Tricia, we're going to call Paula Smith. Oh, are they going to leave, do you think? Tricia, can you let DHHS know, can you ask them not to go too far? Thank you very much. Welcome.
My name is Bill Gessner, and I am pleased to be able to talk to the folks here about the establishment of a primary care residency program in family medicine in Coos County. Chairman Rochford and other members, thank you for inviting us. I grew up and was educated in New Hampshire, and I grew up in Lancaster and attended the University of New Hampshire and followed that by the Dartmouth Medical School. Following completion of a family medicine residency program at the University of Colorado, I joined a practice in Newport, New Hampshire, and began a family. That practice was a part of an establishment to improve conditions for folks in the Newport-Sunapee region, and there was a large population of underserved people there. I had many medical students with me and several residents who I helped educate. In the early 1980s, I then joined New York Medical College Family Medicine Residency, which was located in Kingston, New York, and Woodstock, New York. Its original title was Ulster County Rural Family Medicine Residency Program, stressing the need for more practitioners there. The Hudson Valley woefully needed primary care providers, and the development of training programs for family physicians was the answer. To them, it was the answer, and it worked. I was the residency program director at that institution for nearly a decade. In 2013, I moved to northern New Hampshire and commenced practice in Gorham with Coos County Family Health. My involvement followed a call by the CEO at that time, and who described the critical need for primary care providers, and so I went back into practice. I'm program director of the planned White Mountains Family Medicine Residency Program. It's an educational entity sponsored by members of the White Mountains Medical Education Consortium. The consortium includes medical practices of Coos County Family Health based in Berlin, Colebrook, and Gorham, and the hospitals and medical practices of North Country Health Care, which includes Colebrook, Berlin, North Stratford, and Lancaster. So our targets have been primarily Coos County, but we certainly serve people from adjacent counties, not only in New Hampshire, but in Maine and Vermont. Establishing a residency program in family medicine is challenging. With additional funding, we can succeed. Primary care physicians are nationally increasingly difficult to attract, especially in rural areas. However, there is good data reflecting the fact that graduating residents often settle within 30 to 40 miles or even closer from their residency programs. This applies also to those who have completed rural residencies. Salaries for residents need to be competitive with other family medicine residencies. Faculty and resident educational opportunities are required to be ongoing and often expensive. Fortunately, we have developed relationships with other residency programs in the Northeast, and these may result in quality collaboration among entities. The Accreditation Council for Graduate Medical Education, also known as the ACGME, is that arm of the monitoring body for all residency programs of any nature, whether they be pediatrics, whether it's surgery, family medicine, etc. And they have strict guidelines for curriculum development, resident work hours, resident wellness, performance evaluations, and many other requirements, all working to try to make sure that the residents who are taught are able to successfully complete the American Board of Family Medicine challenges. A site review of our residency program occurred in October of this year, and the formal application of approximately 400 pages was submitted later.
Dr. Gessner, I'd hate to interrupt you, but I'm getting messaging from my staff that our limit is up. Could you leave that copy with us, that letter?
I can leave a copy, this copy or another. I just want to mention that we were approved.
Oh, great.
By the ACGME, and because the application was complete and per them merited accreditation.
Now, how many residents do you anticipate having in the North Country under the program?
Turn this over to Sergio.
Yeah.
So we're accredited for what they call a 444 program, 12 residents total, 4 each year for PGY1, PGY2, PGY3.
Yeah, I can't. Yeah, I'm sorry.
I'm sorry. So we're approved for a 444 program, 12 residents total once we were completely up and running. So 4 residents a year.
So 4 residents coming to Coos County every year. I can tell you from experience that would be a huge, that'd be a huge improvement from what we have now.
We believe so. Absolutely.
Yes. Yeah, definitely. Any other questions from the committee? I see none. Dr. Gessner, maybe you can go and catch a few runs at the ski area this afternoon and enjoy this beautiful day. I had a hint.
He's been ratting on me.
Yeah. I know your secrets, maybe.
Yeah, that's right.
Yeah. Yeah. Well, thank you for coming in, and we'll make sure that that testimony gets to all of our committee members.
And if any of you have any other questions, you can always find us. We're available, and we'd be glad to expand upon this topic.
Great. Thank you very much.
Thank you.
Paula Smith. I can't hear it.
Doctor. Do you want me to let you know when this is?
Oh.
I'll let you know when it's off.
Yeah.
There's some deals, I think. Which way is on for getting up in the minutes?
Paula, welcome.
Yes, thank you. So I'm actually Jody Harper. I'm here on behalf of Paula
Oh,
Smith.
all
Paula,
right.
She has a flu-like virus, so we want her to stay home.
So Jody Harper.
Yes,
We just
yep,
want to
so
make
I'm-
sure the record.
Yes, I'm listed next on the sheet.
Oh, all right. We'll
Yes.
get. I'm not going to give you 6 minutes.
Okay, that's okay. I will be as brief and efficient as
All
I
right,
can.
thank
So,
you.
good morning, everyone. Thank you so much for having us today. I'm Jody Harper. I'm the Associate Director of the Southern New Hampshire Area Health Education Center. And of course, I'm here on behalf of Paula Smith, who's been our director for the last 27 years since AHEC came to New Hampshire. So our mission is to support workforce development activities for current and future healthcare workers. We do this in a lot of ways. In 2024, we offered continuing education to 1,877 healthcare workers, sharing knowledge about topics like diabetes and substance use disorder, among many others. Since 1998, just under 64,000 clinicians have participated in our trainings. We take some of the burden off of the healthcare workforce by offering trainings in the community about chronic disease, chronic pain, and diabetes self-management. More than 3,000 individuals in New Hampshire have participated in these programs since 2010. Our research project shows that people who participate in these programs have better outcomes, health outcomes, and show increases in their ability to participate in their health and manage their own conditions. The AHEC Health Career Catalog is available in print or online, and we share that at elementary and high schools, middle schools, libraries, healthcare workplaces, anyone that will have us. The catalog helps with decision making for students and adults about what they might want to pursue for careers in healthcare. We also offer summer health career camps to youth and offer other programs during the school year to help with career planning and goal setting, as well as offering science enrichment programs. In addition, over the last 12 years, we have trained 300 community health workers, like Christine mentioned earlier, who contribute to the health of New Hampshire residents. At AHEC, we also support the Healthcare Sector Partnership Initiative, which convenes healthcare employers and academic partners in 5 different regions of the state to address the workforce needs. There are 2 very special programs that came out of this initiative, which are the New Hampshire Healthcare Heroes Awards, which recognizes people who are providing exemplary care in healthcare, and then the New Hampshire Needs Caregivers Program, which we've also heard a lot about. And through that program, we've helped 796 different individuals become LNAs here in New Hampshire over the last 4 years. This has helped hospitals, long-term care facilities, and home care agencies better care for their patients. Partnership is the name of the game for us at AHEC, and we have many strong partnerships across the state that help us achieve our mission. One of those is the New Hampshire Nurses Association. So SB 244 provides funds through AHEC to support a New Hampshire Nursing Workforce Center. We are committed to working with the Nurses Association to develop this center so that we can have the capacity to better understand the needs of a sustainable nursing workforce and help identify the existing gaps. The AHEC network gets a limited amount of federal funding from HRSA, and we're responsible to make up the budget with other revenue, which comes from grants, contracts, and registration fees. Having funding support New Hampshire from the state of New Hampshire would allow us to focus on building the healthcare workforce pipeline in a more consistent manner across the state and meet the needs of the current and future Granite Staters. We partnered with Bi-State Primary Care Association since the beginning of AHEC and look forward to continuing our work with them. We need these workers in healthcare to take care of all of us in the future. So I invite you to invest in the healthcare of New Hampshire's workforce.
Great. Thank you, Jody. Do you want to leave that with us? Or
Yes, yep. And I
okay.
believe these, I kind of scribbled on a little
Yeah,
bit, but
well, if you don't want to leave it, you can email it to us.
yeah,
That's fine.
Paul has
Yep.
also submitted written testimony.
Any
so.
questions from the committee? No, thank you very much.
Thank you.
Oh, she did. Okay. All right. Paula Smith sent us her
Yes.
stuff,
Yep.
so that's good. All right. Peggy Gilmore. I'm going to use it. I can't hear your. Oh, Senator Peggy Gilmore. I apologize. The Honorable, right?
The honorable.
Yes.
No apologies. I apologize. I'll be very brief, Mr. Chairman. For the record, I'm Peggy Gilmore with Freddie Strategies, representing the Greater Nashua Community, Greater Nashua Chamber of Commerce. You've heard about the specifics of the bill. I'm here simply to reiterate the support the business community gives to any way that we can mitigate the healthcare workforce crisis that we've all faced. Wendy Hunt, who is the CEO, would like to be here to testify, but to escape the cold weather in New Hampshire, she's on her way to Antarctica.
Oh, jeez. It's summer down there, right?
Yeah.
I think it's,
But the chamber represents over 400 businesses in the greater Nashua area. There are big ones, there's small ones, there's one each of everything. Healthcare institutions, manufacturing, everything. And each and every one of them is impacted by the lack of adequate access to healthcare workforce. The healthcare institutions, we have 2 big hospitals, are impacted, of course, directly, plus our community health centers. But there's such a ripple down effect to every business, every employer about not having good access to a qualified healthcare. So I'm here to lend the support of those 430 businesses in New Hampshire and say to you, fix it. It's not a silver bullet, but it's a little bit. Thank you, and thank you for your support. And I would certainly answer any questions, but there are really qualified people who are doing that.
All right. Any questions? No. Thank you very much. All right. Pam DiNapoli.
Good afternoon. Good morning, I guess, still. My name is Pam DiNapoli, and I have recently retired from the University of New Hampshire as a faculty in the nursing department. I'm currently a school nurse in the Manchester School District. I represent the New Hampshire Nurses Association, and I serve as a member of the New Hampshire Workforce Coalition. So I'm not going to repeat what's been said, but I just want to draw your attention to page 2 of the bill, lines 13 to 19. And it describes the New Hampshire Nurses Association engagement in developing a New Hampshire Nursing Workforce Center. So I just wanted to describe that a little better. Every day we hear about the severe nursing shortage with dire projections of shortages within the next decade. However, we do not track specific data to comprehensively understand the problem. SB 44 provides funds through the AHAC to develop a New Hampshire Nursing Workforce Center. By establishing a New Hampshire Nursing Workforce Center, we will have the capacity to better understand the needs of a sustainable nursing workforce and help identify existing gaps. New Hampshire is one of only 5 states that does not have a nursing workforce center. NHNA's request for funding is to conduct a specific scope of work to be completed within 2 years as a preliminary step to building the infrastructure for a nursing workforce center. The scope of work will involve 2 things. 1, bringing stakeholders together to build a collective voice for nursing excellence in New Hampshire, determine what data collections are ongoing and what initiatives are needed. Second, we will hold listening sessions to determine the needs of the state and make recommendations for the infrastructure of a New Hampshire Workforce Center. We hope to answer the questions: what will New Hampshire Nursing Workforce Center look like? What will it do for New Hampshire? How will we collect comprehensive nursing workforce data going forward? Who will collect it? And how will we disseminate this data with its recommendations? The New Hampshire Nurses Association has been working on a strategy to develop the State Nursing Workforce Center and has recently been appointed as the state rep to the National Forum of State Nursing Workforce Centers. So we have some expertise in this area. I just wanted to remind you, too, that nurses are the largest group of healthcare providers in the state and also the most trusted. So we encourage you to support SB 24 to continue to provide essential quality health care to the citizens of New Hampshire with a robust nursing workforce. And I've submitted my written testimony to the committee.
Thank you very much. Any questions? Thank you.
Thank you.
All right. Maggie Pritchard.
Morning.
Good
Thank you.
morning. Thank you
gonna
for
be
being
very-
patient. You've
I'm
been
gonna
there
be-
very patiently.
I will be very quick because it's hotter than hell in here.
It is.
God. Okay.
I don't know. I'm hot.
We'll switch. No, I don't want that seat. Anyways. My name is Maggie Pritchard. I'm the CEO at Lakes Region Mental Health Center, and I happen to be the president of the Community Behavioral Health Association in New Hampshire, which represents all 10 of the community mental health centers. We are here in support of this bill because we know the workforce shortage is real. We understand that we can't fix it by ourselves, and that me going out and speaking to high school students at the top of my lungs, begging them to be healthcare workers, doesn't work. I have to have your help. I have to have a systematic change. I don't want to go to the legislature and ask for big pots of money at once because, like lost sleep, you can't catch up. right? So when we had to do that, it's because we hadn't had a Medicaid increase for years. And that doesn't really do it. It doesn't attract people to the field. It doesn't keep people in the field. We need to attract young people to this field more. I've done my part. I had 2 children. One designs psychiatric hospitals. She's an architect. The other guy, I sent him to nursing school, but he's now going to be a PT person. But that's okay. They're still in healthcare. So I ask you as legislators to give careful consideration to this. It's a lot of money, but it's a lot of investment that's really needed. And people aren't getting better without anybody to take care of them. So thank you for your time. Have a great day.
Great, thank you. Any questions? You're free to go. Thank you. Thank you for being so patient. All right, we're on to page 2 finally here. Amy Moore. Welcome.
Good morning.
Good
Thank
morning.
you. My name is Amy Moore. I'm serving currently as the board president for the Granite State Home Health and Hospice Association. The association advocates on behalf of home care, hospice, and palliative care providers and the people they serve. So people literally from birth to end of life. I'm going off script a little bit. So I'm also the vice president of in-home services at Essentia Care Alliance, where we serve about 400 people throughout the state. I actually sat right here, it was 2 years ago, for the System of Care bill. And at that time, we were at the point where we we're going to have to close our doors along with other providers throughout the state because the CFI program had been underfunded by $153 million. The work that was done in that last session was incredible. We had a historic rate increase, kept our doors open. And I will tell you that after that, within Essentia, we were able to serve between 4,000 and 5,000 more hours of care a month. That means that was huge. What I've seen in the past 6 months is that it for 6 to 9 months, it plateaued, and now it's like kind of dropping down because, like any other business, we need to keep up with it. We don't want to go into a crisis situation again. When I sat here 2 years ago, I was telling the story of a young man who was my age, a little younger, and I'm not that old, who died alone in his home. He had tried to transfer himself from his bed to his wheelchair. He fell, hit his head, and he laid there for a couple days before he was found. That's because he didn't have care. We were at an absolute crisis point. I've done this work for 17 years. I'd never seen anything like it. What happened 2 years ago was life-changing for this program that is fiscally conservative and that is the option to keep people in their homes. It was a game changer, but we have to keep up with it. We can't get into that crisis space again because I can already see it happening. This needs to be a continuous investment. And while I know that things aren't good and you guys have so much in front of you, again, I don't want to sit there. This, if we just keep up with it, right? Instead of getting into that crisis point of being underfunded, it truly is, as Jim said earlier, others have said it, the system of care is just that. One affects the other, right? In home and community-based care, if we don't have workforce, then the hospitals can't discharge, right? We've seen that. Do you know what that means? You bring your kid in, whatever. A friend of mine recently, her mom took a fall. Well, she sat in the hallway of the hospital for 2 days before she was admitted to a room. That shouldn't be happening. And if our system, right, is robust and we're taking care of it, that won't happen. But one truly affects the other. We're all in this together. And again, I cannot thank you enough for what happened, last session, the investments that were made. But I truly hope that we can keep up with that so we don't get to that space again. Any questions?
Thank you. Any questions? No, thank you very good. 1 second to spare.
I see.
Perfect, man.
Yeah, thank you.
That's good.
I didn't read it well.
Look at that. You didn't even need that, and you came in right on. Adrian Sass. Yes, come on up.
Mr. Chair?
Yes.
We have another person from the opioid treatment providers. Would it make sense for them to both?
Absolutely. Is it Tiffany?
Yes.
Yes, that would be great.
Thanks.
Thank you, Mr. Chairman, and the committee for having me today. My name is Adrienne Sass, and I'm the Regional Director for Acadia Healthcare's Comprehensive Treatment Centers. I oversee 9 OTPs, which are outpatient treatment programs for opioid use disorder, in Vermont, New Hampshire, and Maine, and we serve approximately 4,000 patients every day. Like many of the people that you've heard from today, we are also experiencing extreme staffing shortages, specifically with clinical and nursing staff. I'm going to go rogue a little, and Susan might whack me, but I want to take a moment just to emphasize that we are not just methadone clinics. We really meet people where they're at. We meet people before they are even our patients. And we know that addiction affects every aspect of a person's life, and therefore recovery must do the same. So we offer a myriad of services outside of just methadone. And that includes individual counseling, group counseling, case management, nurse care management, primary care coordination. At my sites, we have telehealth rooms, and through collaborative partnerships with local hospitals and service organizations, we can set someone up with a primary provider who's going to offer non-judgmental treatment. Our folks are oftentimes very afraid to seek treatment or just general health care elsewhere because of stigma, and because they feel like they're going to be judged. As you've heard, we need to be able to offer not just competitive wages, not just livable wages, but competitive wages. And that's because we deal with an extremely medically fragile population. So we need highly skilled healthcare professionals to work with those individuals. And the Medicaid rate being 45% less than the Medicare rate prohibits us from being able to do that.
Good morning.
Good morning.
My name is Tiffany Dreyer. I am the Regional Director for New Season. I oversee 8 of our outpatient centers in the Northeast region, and 5 of those centers are in New Hampshire. We have a site in Manchester City, and then we also have another site in Manchester, which is our Manchester West office, in addition to Concord, Franklin, and Keene. Out of that, we have served over 3,000 patients this last year in 2024. And to Adrian's point, Medicaid is a big population that we serve. We have over 50% of our patients that have Medicaid funding, and we are always looking for counseling services. So any new counselor that is coming out of grad school, we're trying to swoop them up and bring them right into our doors so that we have services to offer for our patients. Nursing is also a huge struggle as well in the state of New Hampshire. And I think that is something that we really need to take a look at as far as our wages in terms of the funding that we receive from Medicaid services. It would be great if we could get to that Medicare rate or close to that Medicare rate in order to fully staff our centers so that we can continue to serve our patients on a daily basis. I have been working directly with our patients in several of our offices to hear about their concerns and just their stories. You know, to be in this field, you truly have to have a passion for that. And I think that's something to take into consideration as well. So we, as I said, on behalf of New Season, are here to support this bill, and we hope to see some change in the future. And I appreciate your time.
Thank you. One of the questions I had, it's in that section 5, Roman numeral 3, that it talks about $2.6 million for opioid treatment programs. I think somebody brought this up earlier, and there's no definitions that we have here. What is that a defined term somewhere, opioid treatment program, or is that as broad as I think it is?
It's so the opioid treatment programs are the OTPs.
Okay.
And we are very specific.
So there is a
clinics.
definition somewhere that,
Correct.
okay, all right. Because I just didn't, you sometimes see this thing, and I didn't, anybody who prescribes Suboxone is considered, but you're telling me there is a formal designation.
It's a formal
somewhere. Okay.
designation through the
Perfect.
federal government.
Yep,
Yes.
that's all I needed to know. Thank you. Question?
Thank you. You brought up the fact that Medicaid rates are 45% less than the Medicare, right?
Mhm.
Does this bring it up to parity?
We hope so.
I mean, to speak on behalf of New Season specifically, and just to the point that a woman earlier had made, I think what needs to occur is that continuous increase each year versus looking at it over a 10-year time frame, or you're looking at it from, okay, in 8 years we'll make another increase. I think there needs to be a definite approach where we're prioritizing this. You know, you see it all over the news with specific to the opioid use overdoses continuously happening, the deaths that are occurring. And sure, there are other ways that we are trying to prevent that from happening. But when we continuously are having turnover because of the rates that we're receiving and we're not able to pay counselors and the work that they're putting in on a daily basis, working with really difficult populations and hearing stories day after day, that can lead to burnout. And then when you're trying to cover a caseload because you just had another counselor leave, it increases that. And then they're not willing to just continue to work at a higher caseload because it's impossible to find another counselor to come in until 3 months later. And to the point of also with nursing, if we don't have nurses, we cannot dose. You have to have a nurse on staff at all times. And there is a huge nursing shortage in the state of New Hampshire, just based off of the other states that I also oversee.
And I think that the 2.6 million was, from my understanding, was earmarked for OTPs and rate increases. And we did see a small increase in 2024, which we were very appreciative of, but it wasn't what we had hoped, and that money has not been disseminated. There are a lot of wonderful creative initiatives around opioid abatement funding, but at its core, we need the Medicaid rates to come up so we can offer basic treatment. We're happy to do all the other creative things that we're doing out in the community, but we have to be able to serve the folks who come in our door every day, and we're open 7 days a week.
Just a quick follow-up, and I know so you just said that the money hasn't been disseminated yet?
That is my understanding. It was earmarked.
The Medicaid rate increases for the OTPs went into effect, and so the increased rates are that were appropriated in HB2.
Okay, just a clarification, so that means you're getting it now.
We've received an increase in funding the beginning of the year, yes, in January.
Okay. Did you have a question?
Or Senator Long.
Thank you, Mr. Chairman. So I'm looking more at numbers of those you could help. So how does this affect your capacity? We could help 100 people, but what's happening now is we're able to get to 60. I'm more interested in actual people that can be serviced.
I can say for my sites, we are understaffed, which means we have to request specific waivers from the State Opioid Treatment Authority to be able to serve more people than we have the staff to actually serve. So it's one clinician to 65 patients, and it's one nurse to 150 patients. So we have specific ratios that we have to operate within per state guidelines and DEA guidelines.
And I'd follow up on that.
Yeah,
if I may.
absolutely.
Thank you. So the programs you have, and I know entities are creative in setting up other less expensive programs. So with respect to what you have to offer, what has been the decrease in what, if I was going to you for substance use disorder, what would I be lacking in, knowing, we know, okay, here's the best practice. This will give you your best option. What do you have to back off on? I don't know if you understand.
Sure. So I think what would occur then, so for instance, with 2024, we had about 3,000 patients that we served for New Hampshire specifically, with about or more 50% of those were Medicaid funded patients. So you're looking at 1,500 patients, about maybe closer to 2,000 patients that we were serving with Medicaid. If a patient comes in, so the primary focus is that they get counseling services, they receive their medication, and they're also seeing their prescriber on at least a quarterly basis. And then we're looking to get them connected up with peer support as well. If at any point in time we are short-staffed, they are going to be lacking those services, and they will not be getting the utmost treatment that they deserve when they're coming into our doors. And the harm that is occurring is when you have a counselor and they leave, and then you get transferred to another counselor, you have to then again retell your entire story, which is incredibly frustrating for our patients on a regular basis. So in order to prevent those situations from occurring for 1,500 patients, about 2,000 patients, we would like to retain our counselors, retain our nursing staff, so we're not having to guest dose them at another center because we don't have a nurse for the day because they called out sick and we're short-staffed. We don't want them to have to pay an extra couple of dollars if they go outside of a treatment center that is not within our company. You know, we want to make sure that they have the treatment services that they deserve and not having to do the bare minimum for our patients, because that is not going to help them be successful in their recovery.
Okay, and just one more.
Yeah, absolutely.
I understand you're concentrated on Southern or Western. Do you find people coming from, North Country or seeking these services instead of being able to, where they would be best apt to succeed in their community, moving south to seek these services?
We see people who travel sometimes up to an hour and a half or 2 hours a day to reach a clinic, just because it is very regulated and you can't just every town can't just have an OTP. So people travel great distances to get to us, and those are barriers that we're trying to reduce. We're trying to expand. The state is open to having more facilities, but again, it's a huge undertaking. And so for now, we try to do the best we can to support patients to be able to get to us through Medicaid rides or ride shares, offering gas cards. But those are the types of things that, again, without being able to pay appropriate wages and be able to retain staff, it's really difficult for us to do those extra steps. For example, if we only have one nurse and they're dosing all day, then they can't do the nurse care management with patients who are sick or need a primary care and getting that set up, because they're just focused on dosing. That also means our wait times are extremely longer. So instead of being able to come in and get your medication and see your counselor and go, you may have to stand in line for 30 minutes because we only have one nurse. Oftentimes what that does is put strain on the emergency departments, because people with jobs will say, I can't stay here for 30 minutes because you're short staffed. I'm going to go to the ED. And then the ED gets flooded with patients because we have nursing shortages, because we simply can't pay competitive wages.
Right. Thank you.
Any other questions? Oh, thank you.
Thank you very much.
Holly Stevens.
Good morning.
Good
Chairman,
morning.
members of the committee. Thank you for the opportunity to testify this morning. My name is Holly Stevens. I'm the Director of Public Policy for NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a grassroots organization whose mission is to serve all people with mental illness and suicide through support, education, and advocacy. I'm here today to speak in favor of Senate Bill 244. Christine Stoddard, I believe, delivered to you my written testimony, so you should already have that. 1 in 5 adults and 1 in 5 youth aged 6 to 17 experience a mental illness each year in New Hampshire. That number for youth has increased this past year. It used to be 1 in 6. It is now 1 in 5. More than half of the people with a mental health condition in the U.S. did not receive treatment last year. Of the 70,000 adults in New Hampshire who did not receive the mental health care that they needed, about 41% of those did so because they could not afford care. Granite Staters are over 3 times more likely to be forced out of network for mental health care than primary care, which contributes to the increase in out-of-pocket costs for them. In 2021, nearly 40% of adults in New Hampshire reported symptoms of anxiety and depression, and 17% of them were unable to receive the care that they needed. Due to the workforce shortage, many mental health providers have opted not to engage with the commercial insurance industry, but they just take cash paying clients instead. So we have a bunch of folks in the state of New Hampshire who can't afford care because they can't find a provider who takes their insurance. NAMI New Hampshire has heard countless stories of people who have been given about a list of 20 names from their insurance providers, and they call all 20 names, and not a single one of them is taking new patients. And that's what we call ghost networks. Those are networks that they have, but there's just no providers taking anybody. In addition to commercial insurance shortages, due to low Medicaid reimbursement rates, there is a shortage of therapists who accept Medicaid. This includes the community mental health centers who struggle to recruit and retain therapists because the salary that they can offer is less than private organizations due to low Medicaid reimbursement rates and the high percentage of Medicaid patients that they see. Furthermore, there is a shortage in case managers. Case managers are a critical treatment team member for those who have serious mental illness. Case managers assist in individuals with all activities of daily living, including coordination of appointments and transportation. They also help with things like housing and food. Senate Bill 244 would expand the state loan repayment program to include bachelor level. I'm just going to say you have my written testimony. I'm going to end right there for you, and we do support this bill. Thank you very much.
Thank you. Any questions? No, thank you very much.
Thank you.
Let's see, Teresa Rosenberger.
Mr. Chairman. Thank you. I'm Teresa Rosenberger from the law firm of Bernstein Shore, and I'm here today representing the New Hampshire Association of Naturopathic Doctors. One of the doctors was going to be here, and she got vertigo, so you get me. So yeah, well, it's terrible. I'm taking a different tact on this, and I signed up as neutral. And the reason I'm taking a different tact is that I think we maybe can offer you a solution, not a total solution, but the beginning of a little baby step of a solution that's cost effective and fairly immediate. The naturopathic doctors have been licensed in New Hampshire since 1995. They've been practicing for 30 years. The statute allows them to be trained and practice primary care medicine as well as some specialty care like Lyme disease, etc. They have been accepting private insurance since 2013. And what I'm going to offer you for the solution is they are eligible to accept Medicaid, but they are not credentialed in New Hampshire. We've met with Mr. Lippman at DHHS right around the holidays just to start talking about this, because these doctors are available. They, at other states, they accept Medicaid and they have Medicaid patients. Some doctors actually in Vermont have as much as 50% of their patient load is Medicaid. We've talked to Mr. Lippman, and the state could either amend the state plan and add them in and allow them to be credentialed, or they could do legislation. So I'm only here to let you know they do practice primary care. They, as we all know, if you go to primary care, you might avoid going to the ER, and if you've got an issue and you call your naturopathic doctor instead of going to the ER, it saves the state money. They do have access, and I just offer that as one step that probably wouldn't cost you an awful lot of money and would be fairly immediate. Well, I don't know how fast you could get credentialed, but fairly immediate as a solution. Happy to answer any questions, or have them made available to you at some point to answer other questions.
Thank you.
A different tack.
I've worked with this group for a long time,
Yeah.
and they're just a wonderful group of professionals, and I have no doubt that they can do what you're telling them to do.
Thank you.
I would tell them, be careful what they wish for. Be careful what they wish for. I mean, it's, I understand and I get it. I mean, they're excellent primary care providers, but I would hate to see them hurt.
I appreciate that. We have thought about it long and hard, and before we went to speak with Mr. Littman, because as we know, the Medicaid rates are low.
Sure.
But
Oh, sorry, go
no,
ahead.
I was going to say, and the federal government allows them to be credentialed for Medicaid, but not Medicare. Shame on the federal government, because that could save money and give you also more access to providers.
So is this credentialing, is this something that has to be done through statute, or is this a departmental action?
I'm going to defer to the department and Mr. Littman's not here, but when we did talk to Mr. Littman, some states have just amended their state plan.
Yeah.
Some states have done it through statute. And as far as we're concerned, we are happy to do whatever works best for the department. If
Okay.
we just like to get credentialed and be able to serve these folks.
All right.
So I'm only offering that.
If we don't do it with this vehicle, I would love, there's open invitation to help you out with that.
I will.
Again,
We
just
will
be
have a
careful what you wish for.
conversation.
Any other questions?
Any other?
Thank you very much.
Thank you very much.
Rebecca Sky. Yes, I should know that because you were here.
Simplicity is confusing to many.
Well, that's all right. I have been a career of reading doctors' handwriting, so I should have been better at that. So.
Okay, so thank you again for your time today. My name is Rebecca Sky. I'm the Executive Director for the New Hampshire State Commission on Aging, a legislative commission that was established to advise the governor and legislature on issues related to aging, given the rapid, permanent demographic shift our state is undergoing. This testimony that you have before you was co-authored by myself and Lori Harding, a governor-appointed member of the Commission on Aging. On behalf, and we submitted on behalf of the commission in full support of this bill. As you've heard and know, New Hampshire is facing a significant shortage of healthcare workers. The commission focused particular attention on direct care workers, including personal care aides, licensed nursing assistants, community health workers, nurses, and other care partners because of the growing need for support for older adults. So what is the shortage? You have a beautiful graph on the written testimony that I provided for you. It is from the New Hampshire Department of Employment Security. And basically it says that there was an overall a decrease of 12% in the long-term care workforce and 23% specifically within the skilled nursing workforce between 2015 and 2022. And we all know that this problem did not begin in 2015. So in consideration of time, I would like to just point out, pay attention to two aspects, particular aspects of this bill. One is regarding the program New Hampshire Needs Caregivers. It's a proven program. It was funded, and it's out of funds. It was funded through COVID funds, and over its 4 years, you heard that it trained almost 800 individuals to become LNAs. Findings from a federal health professionals opportunity grant suggest that subsidized training and supports, which include childcare and transportation, offered by this type of program improves training completion. I just want to say that this program is a steal. It takes people, it recruits people to become interested in getting that LNA training, takes them through the training and their first year of employment. Another piece of what they do is they coordinate trainings too. So when you look at our western region of the state or the northern region of the state, there may be a nursing home. In one of those regions, there's one nursing home that has two, let's say, housekeeping staff that might be interested in becoming an LNA. There's another nursing home 20 miles away that has another, and one 20 miles away in a different direction that also has a few people who might be interested in becoming an LNA. And these nursing homes have, during the time that the program is in operation, would call the coordinator, and the coordinator would keep track. And then when they saw that there was a significant number in a region, would arrange for a program. I just can't say enough words about it, the value of this particular program. And I just will end by saying one of the most critical parts of this bill is the 3% increase in Medicaid reimbursement. And you've heard it before. There is a need to address regular increases in salaries, which can only happen with regular increases to reimbursement. Thank you for your time.
Great, thank you. Any
Speed reading.
questions? No, we're good.
Thank you.
Thank you. Brendan Williams. Yes.
Thank you, Mr. Chairman and honorable members of the committee. For the record, Brendan Williams, I'm the president and CEO of the New Hampshire Healthcare Association. We represent long-term care facilities throughout the state of New Hampshire that are capable of serving over 7,000 residents. And not to keep belaboring this bill, but we obviously support this legislation. I've given you some written testimony. Nationally, since the COVID-19 pandemic began, nursing home wages are up 32%. But despite that, the nursing home workforce in New Hampshire is down almost 8% since February of 2020. And so we can use all the help that you can give us when it comes to Medicaid rate increases in order to try to build back that workforce, because obviously the elderly population with care needs has increased exponentially since February 2020. So the fact that we're not even back to that staffing level is obviously concerning. And we've seen facilities that have turned away prospective residents. We've seen facilities that have waitlisted prospective residents, county homes even, Maplewood in Cheshire County. The Hillsborough County Nursing Home has had a wait list of over 100 prospective residents seeking admission. So there are needs throughout the state. And Mr. Chairman, I think you win the prize for most nursing homes in a district. But there are a lot of other nursing homes out there that need rate increases. And whether you're in Berlin or Wyndham, you're going to need a rate increase. And I think the predictability of the methodology in this bill is to be commended. Finally, we support the New Hampshire Needs Caregivers program. It was really unfortunate when the funding for this program went away, but was as was stated earlier, whatever we can do to get licensed nursing assistants, the frontline caregivers in any nursing home, into the pipeline, that program is worth every dollar that you invest in it, and it's a small amount of dollars, but we really do support that. So with that, I would yield to any questions, and I thank you for your time.
Thank you. Just going back to 2 years ago, we put in the budget an increase in nursing home rates, and it was a 3% increase. But what I'm hearing from my nursing homes is they're not netting through. It's not a net increase of 3%, and they're like 2.5%, 2.7%, which some people think that that's not a lot, but that's a significant amount of money when you're talking millions and millions. So this 3%. Are you going to get it? And why aren't you getting the 3% that we gave you? I mean, I'm not saying but I want to know. I mean, we all thought that we were doing a good thing and putting a 3% increase, and our nursing homes aren't getting it.
Well, the nursing home rates are adjusted twice a year, and they're based on what's called case mix, so the medical acuity of the residents. And there are instances where, because of adjustments to the case mix index, a facility might actually see a decrease. I think that probably the better way to put it, Mr. Chairman, is that you're increasing the amount of funding available to nursing homes by 3% each year under this approach. Whether that means a nursing home actually gets a 3% increase is going to depend entirely upon its case mix index.
Now, would this bill, the way it's written, would the same scenario play out?
It could. I know that before there was a time where where legislation actually specifically provided that there had to be a 3% rate increase. And so that was actually, the department can correct me if I'm wrong, but they would give us a rate sheet, and then separate from that rate, they would have the 3% add-on. So you could actually see discretely the 3% add-on, and each facility, regardless of its case mix index, got that increase.
Okay, great. Thank you. Any further questions? That's it.
All right. Thank you, Mr. Chairman.
That's the end of my list. Is there anyone else that would like to speak that hasn't spoken on HB 244? With that, I'll close the hearing. And I'm going to take a 5-minute break before we get our next one here. Yes. Otherwise, we'd have a problem.
So where's the money going?
I told John that you want to talk.
Yeah, he was just talking to other senators, so I was like.
Yeah, I said just because, yeah.
I'll just hop down here.
Are we on afternoon yet? We are 10 minutes away from this afternoon, and so we will move right along. Good morning. For the record, my name is Sue Prentice. I'm a state senator from District 5, 15 communities spanning the great Upper Valley and right down to New London, the only one in Merrimack County. And I'm here today, and I've asked Dr. Amy Lee. I always want to call her like Amy Parker. I don't know why, but Dr. Amy Lee, who is an obstetrical resident at Dartmouth Hitchcock and also lives in the same city that I do. So this is great. I've asked her to join me. It makes it easy. We can do this all at once, as well as this was her idea and her initiative. And as I close out my testimony, I'll talk about my commitments to maternal health care. So this should not be a big surprise. And I'm coming before you today with Senate Bill 137, which is relative to hospital stays covered under the state Medicaid plan. So we're talking specifically here, we're making an ask for new moms that have opioid use disorders whose newborns are sick. They are struggling with neonatal opioid withdrawal syndrome. And I think we can all agree that this is this is truly a vulnerable population, not just the moms, but these babies. So I did a little look back because Dr. Lee, who again keep wanting to call Parker, will focus in on some of the more say today specific data and research that she has. But I did a little look back into like New Hampshire numbers. And in 2017, the University of New Hampshire did a study, and it was a 10-year study. So they published their study between 2005 and 2015. So I think what we all know about healthcare data is it always runs a little bit behind. But this is an interesting window because I'm going to just pair it up with the New Hampshire News Bulletin article from 2024 that says the same problem exists, but that article looks at it at a more national scale. But looking at this, they said there's a 5-fold increase in infants who are born that are addicted to opioids. And I don't think, sadly, that this is a great surprise considering that we have been on the front lines of battling an opioid use epidemic in this state. States across the country, but we're talking about here. So there's a 10-year window, and it focused in your district, Senator Rochford, it talked about Berlin. So not to pick on any one particular community, but that's where they published some of the data from. So there's about 100 babies born every year at Androscoggin Valley Hospital. And in 2015, 8.5% of those babies that were born at AVH were in active withdrawal from opioids.
What percentage?
8.5 out of 100 in 2015. So, but when we looked at the statewide average, so it said this percentage is dramatically higher than the state average of 2.4% of babies born within or suffering from withdrawal. So it's a smaller number. It's a part of the state that has been definitely highly impacted, but this, that's what the study from UNH said. And I think that it's doubled, more than double compared to the statewide average, but it's looking at one particular population. So I thought it was interesting in this particular article based on the study, there was a nurse that they talked to who said that the treatment then, so we're talking in that 10-year window, and even in the early, somewhat to the late 2000s, not as close as where we are right now, was these newborns, we call neonates, 0 to 6 weeks old, were put in an isolette, and they were basically isolated in that isolette. And they would, they cried, they cried, they had muscle tremors, they often suffered from a loss of appetite. They were sick and they were struggling. And the line of not just thinking, but practice was that they could, that self-soothing and consoling themselves was how they were going to work this out. And they also, at that time, and it wasn't just a practice at AVH, but it was a practice across the country, was that they knew these children, these babies were in pain. So they would give them actually morphine to help them with the pain because they were suffering. So little neonates, isolated, hungry, unable to soothe themselves, and, just really, drawing this distance and not getting well. And when talking about this, it was a 12 to 17 day hospital stay. Again, so 10-year window, 2005 to 2015, 12 to 17 days, and then it costs $30,000 to $40,000. Okay, so let's think about a 12 to 17 hospital stay now under the same conditions. And we don't have to because we've changed the way that we actually treat these neonates and work with their moms. And that's what we're going to talk about, how they're really a progressive, evidence-based approach. How this little quote broke my heart. They used to just kind of cry. This is this nurse from AVH. And the belief was that self-soothing was a good thing for them. And so that's pretty tough to hear, because we know that, again, vulnerable can't help themselves, but we can help them, and we have. So the treatment has changed. It's now eat, console, and sleep. And the best way to do this is with their mother present with them. But if and when these babies are born and they are suffering from withdrawal, they don't go home right away, because they do need to be monitored in an inpatient setting. Sometimes the moms are still undergoing treatment too. So what we're proposing here is creating the availability and some funding for hospital beds for up to 5 days, so that these moms and their baby or babies, if they had multiples, can be in the same environment, the same room, and they can provide them with the treatment that we now know is actually what works for them. Feed them, console them, support them in sleeping. On average, we're looking at like a 5-day window for these babies to be into a place where they could be and are being discharged from the hospital. So there's just a completely different approach. And AVH said in 2018 that once they started using Eat, Console, Sleep protocol, they hadn't had to use morphine to treat a baby for pain from withdrawal for more than 18 months. So we've seen a wide shift, and we know what actually is working. I'm really thankful and appreciate and honor the work of our nurses and our doctors that don't stigmatize addiction, but see this as the problem that it is, and are working with all populations, but our moms and our newborn babies. So here's our situation, and I've already given you the highlights of it, and then I'll be turning it over to Dr. Lee. If a mom is struggling with co-occurring mental health, trauma, homelessness, poverty, domestic violence, and more, they may be challenged to actively take part in this Eat, Sleep, and Console, because they're not, unless they're co-located. Sometimes they don't have cars, they don't live nearby, and especially where we have less places that babies are being born in this state, we can't always get that mom with them where they need to be. So that is key in this conversation. Senate Bill 137 would cover, again, a rooming in situation for up to 5 days for these qualified moms, and I'll talk about who they are. It's just two pieces, so they can provide what we know is the best medicine: eat, sleep, and console. Besides the room, there is some language that is written in here about potential medications that a mom may need to take, or a baby may need to take, or this neonate, this little newborn baby may need to take. So there's a provision made for that in the language. And I believe at this time the fiscal note still remains incomplete. That being said, in order to qualify for this, this is what I call, and I believe you call it compassionate stay.
Yeah.
So in order to qualify for this compassionate stay, this time where you are co-located, co-rooming in a clinical setting with your baby, an appropriate placement outside of the hospital is not available. So we do know, I do know of at least one treatment, one home, and we're actually working on, there's an effort being led in the Upper Valley to build a second home near DH, but this other one is on the other part of the state where it's close to the hospital, and they can actually, these challenges of being able to get to their baby are narrowed down or almost eliminated because they're so close by. But the truth is that isn't happening everywhere. So we're in this window where we need to work to solve that part of the problem. So they don't have an appropriate placement outside of the hospital, and the postpartum parent's newborn remains on an inpatient claim for monitoring. So this is, just using the Medicaid terminology, monitoring the postpartum patient's newborn remains on an inpatient claim for monitoring post in utero exposure to substances that may lead to a physiologic dependence and continuous care by a postpartum parent in the appropriate first line treatment, and defined here, postpartum parent is the parent that delivered the baby or babies. And I'll close out and turn this over. I'm certainly willing to take any questions, but to Dr. Lee by saying, I think you all know after 4 years here that I've have made a commitment to working to reducing maternal mortality and building a strong foundation for our neonates, for our babies. And you have all, Senator Rochford, you have been here in the House, but Senator Long, you're new to this, but we've all been part of working on these problems together and protecting our most vulnerable communities and working on an effort to decrease maternal mortality and to increase a positive, strengthened, strong foundation for our babies. We need to make sure that we have these systems of care that reach patients and their families no matter where they are located. Senate Bill 137 provides a practical, proven pathway to improve maternal health care and neonatal, our babies, to give them, and it also brings a reduction in costs to our overall healthcare system. So for the moms, for the babies, for the healthcare systems, we have 3 different wins here with Eat, Sleep, Console. And that is my primary introduction on 137. Again, I do not have a fiscal note yet. Happy to answer questions, or we can just move to my colleague and subject matter expert, Dr. Lee.
Great.
And
Thank you.
neighbor.
And neighbor. Great. Thank you. Doctor, any questions for Senator Prentice? Okay. Dr. Lee, are you ready for questions, or do you want something you want to say? Okay. Well, if you have something to say, because you may answer
can
the
I say my
questions.
piece
Yes,
first?
go right
Okay,
ahead. Yep.
perfect. Okay.
Go right ahead.
I'm Dr. Lee. I am a constituent in the Upper Valley of Dr. Prentice, and I am speaking as a provider for the patient population that SB 137 would impact, and I'm urging the committee to recommend ought to pass. Postpartum overdose is the leading cause of maternal mortality in New Hampshire. SB 137 is a critical step towards addressing this crisis and supporting mothers with substance use in the vulnerable postpartum period. When an infant is born to a mother who has used substances such as fentanyl or is on a medication for opioid use disorder such as methadone or buprenorphine, the newborn requires a 5-day minimum stay of monitoring for withdrawal symptoms. The best care for the newborn is a model called Eat, Sleep, Console, in which the parent soothes the infant. Eat, Sleep, Console has been shown to significantly reduce the newborn length of stay in the hospital and also admissions to the NICU. In a recent New England Journal of Medicine study, the reduction was almost half, from 15 days to 8 days. However, there's current discharge policies create barriers to parents participating in Eat, Sleep, Console. How can we fully expect a parent to participate if they're discharged on postpartum day 2 or 3, while the infant needs to stay till postpartum day 5 for monitoring? One of the questions that parents have during this period is, how can this new parent access medications for opioid use disorder while staying present for their infant? And lack of access to these medications for opioid use disorders, such as buprenorphine or methadone, if the parent does choose to stay with their infant, can impair their ability to care for the infant, and it can also destabilize their recovery process, leading to overdose and death. SB 137 would give providers the time to address these questions and set patients on a path for success, ultimately saving lives. I recognize that New Hampshire is experiencing a shortage of hospital beds, but I would say that SB 137 could actually offer a solution. Due to the significant reduction in infant length of stay when parents participate in Eat, Sleep, Console, you would have faster turnover of pediatric beds, as well as a reduction in expensive admissions to the NICU. So in conclusion, I would urge the committee to recommend ought to pass, and I'm open to questions and considerations. I have provided an FAQ sheet, which really goes into details about
how this would work out in practice.
Great, thank you. Any questions? Senator Birdsell?
Thank you, and thank you for taking my question. What, how do the commercial carriers handle that? Do they have a similar program, or is this kind of like a pilot with Medicaid?
So commercial carriers, that's a good question. So generally, most of our patients who need medications for opioid use disorder are on Medicaid, and we're following mostly the Medicaid standards. Generally, the patients who are on commercial insurance do have more resources, such as a car where they could go and leave their infant and go to a methadone clinic. But if somebody doesn't have those resources, they're coming from a more rural state, they may have to leave for hours out of the day and leave their infant alone with the nursing staff, which puts strain on the nursing staff as well to go to take care of that infant when the parent should be the primary caregiver for that infant at that time.
So I've got a question. So the 5-day, and that's, I had and I think Senator Prentice addressed that, but I wanted to get a little more information on that.
Yeah.
That, when I first read it, I thought it was arbitrary, but I'm assuming there's data that shows that's the magic number. And it's, so yeah.
Yeah, so the American Academy of Pediatrics,
Okay.
their recommendation is a 5-day stay to monitor for withdrawal symptoms. However, Medicaid covers only postpartum day 2 to 3. So SB 137 would allow for those 2 extra days in order to get to that 5-day stay for the mom. But it would also be cheaper for Medicaid because we're not trying to come up with medical reasons to keep the mom admitted in a more expensive postpartum stay.
Sure. Which goes to my next question in that, and I don't know if there's data on this, but do we know like what percentage of NICU admissions? I mean, we're reducing NICU admissions. I can't imagine what a NICU day costs. You know, I don't even want to begin to ask that, but do we have any information as far as folks that have gone through this 5-day eat, console, sleep? What is the reduction of, do we have a number as far as reduction of NICU admissions?
I would have to look into that, but I can provide that number to you all via email.
Sure.
Yeah.
And then just on that, and you may not know the question, the price per day for what you're proposing, the 5-day eat, sleep, console versus a price per day of NICU. Do you know that off the top of your head?
I don't know the prices off the top of my head, but I can say that it would be significantly cheaper to have
Not
it
your
day
department.
rate.
I get it. Yeah.
Yeah.
But I know, and I understand that. I can't even, like I said, I can't even imagine. I was in the hospital for 2 days, and it was $90,000, and it wasn't nearly what we're talking about.
Yeah, I think there's the opportunity for savings both in the neonatal and the maternal side. So the neonatal side, preventing that NICU admission, shortening that length of stay for the neonate. And then for the maternal side, if we can discharge them appropriately when the postpartum care is done and transition their stay to a cheaper option of stay, which would be this day rate, that would be better for the maternal as well. Because sometimes what we do is we try to figure out, like, is there a medical reason that we could try to justify them staying even longer and extending their postpartum stay so that they can be with their neonate?
Yeah.
When theoretically they could be discharged.
Right. Very good. Any other questions? No, thank you for coming in. This has been wonderful.
Okay.
Rob Berry and David Chorney. We know what we're going to, I think you probably know the questions we're going to ask you right next.
You might have answers to some of the questions that were just asked.
Again, Rob Berry, General Counsel of the Division of Medicaid.
David Chorney, the Deputy Medicaid Director.
So imagine you're first going to ask, how much is this going to cost?
How much? Yes. Where is the fiscal note?
So again, we have completed it. We just haven't gotten the pipeline to actually get it attached to the bill itself. But as David and I were reading the bill in preparation for this, we think we might have overestimated what the rate may be. So we're going to need to update it anyway. So I think what you're going to see is going to be a little bit higher. Our fiscal analysis was largely based on a global group of people as opposed to not necessarily just focused on mothers. And I think the bill does apply to everybody. But it seems to be that the testimony was really focused on mothers. But
That says postpartum parents.
yes, yeah. Well, the first part. Here, let me pull it up. It's for the client does not meet the criteria for acute inpatient level of care, but is not discharged because an appropriate placement outside the hospital is not available. And then there's an or the postpartum parent thing. So we took it globally. If it's meant to apply just to postpartum, then we're going to be overshooting it as well in our estimate. But again, when you're trying to come up with a fiscal analysis with this, it's especially something new. You kind of have to do a lot of guesswork based on, just reasonable sources. So we assumed it would be about 100 people a day based on some data from the New Hampshire Hospital Association, correct?
100 people a day?
So that's taking the or. So there's not an appropriate. So looking
Okay.
at all Medicaid, all inpatient stays, and there's not an appropriate discharge, or the other part is also the postpartum women. And so I think what we heard in the prior testimonies, the legislation is really focused on postpartum women with babies with neonatal abstinence syndrome. So our fiscal note looked at the cost if we did an administrative rate for
Everybody.
Okay.
So that's
it would be less if we were specifically tailoring it to that the postpartum mothers with a baby with NAS. And I think, as you heard, there are some cost savings that would likely be associated.
So I know what you're going to do this afternoon.
Yeah, we'll be doing more, but so yeah, but so
8% was the high rate from Thoroland. Right.
So it's going to be off, is what I'm trying to get at. Is we're going to be overestimating it. And then we went with the swing. Well, initially we went with, I guess we tied it more closely to the nursing facility rate, but as we were an average. But as we were reading it again, we thought the swing bed rate might be more appropriate. So we tied that to about $180 a day for a swing bed rate, if that's what we go with here. So the long and the short of it, and I feel like I'm at the car repair place where I'm trying to explain everything that's wrong with your car.
We're hammering you questions out of line.
So we are at 6.5 million in general funds at this point, and I do want to mention that we don't think there is a federal match based on the way we originally read the bill. So this would be completely general funds. But that's where we are at. We are at with it at this point.
Do you know what the rate is if there's an average rate for a NICU stay? Daily rate?
I can find that. So the way you pay for a NICU stay, or the way Medicaid pays for a NICU stay, there's the facility, the hospital component, which is a DRG based. And so I can pull the appropriate DRGs and get you the rate. And then also tied to that, which is often sometimes the more expensive part, especially for really high acuity patients, is the professional fees. And that's the NICU physicians and providers that are providing the care to the baby in the NICU.
Senator Birdsell.
So that's 6.5 million that's the whole number for 100 per day.
Yep.
Okay.
Yes. Yeah.
What, if I may?
Yeah, go ahead,
Just,
Senator.
what is DRG rate?
Diagnostic resource group, right?
Yes, and essentially, so it's a diagnostic resource group, and it's related to the patient's diagnosis, and based off of, it's similar to how Medicare prices their hospital stays, and it looks at generally for these patients, what is the length of stay, what is their acuity, and a cost associated with that. And so it pays for the hospital component, also known as the facility component, and it's the cost the hospital would accrue to run the hospital, to have the bed available, to provide the technical aspects of the care. And then separately from that is the professional component, which is also paid, but that's the physician services, the medical services component of a hospital stay.
Great. Thank you. Any further questions? Senator Prentice.
And thank you, Chair Rochford. I think Senator Birdsall may have gotten at this, but I just want to clarify. So the 6.5 million is looking at the whole broad category, but you are going to go back and sharpen your pencils and look at the postpartum parent and, base an updated fiscal note on that, and then we'll be looking at where it is. And so follow up to that.
Yeah.
Do we think there's going to be a federal match to that?
So for the administrative rate, we do not think, CMS previously has told us we can't draw a federal match unless the person meets inpatient level of care. But I think here there's a unique aspect. We could look at whether or not there are cost savings available, especially if the neonate is discharged earlier. The way we pay for neonates under Medicaid is, so it's that DRG system I referenced, but for neonates that go beyond an average length of stay, we'll also pay a per diem rate. So to the extent that we're paying a per diem rate for outlier neonates, and these neonates fall into that group, and we bring that length of stay for them down, we won't be paying that per diem rate. So there could be some offsetting costs.
Okay.
All right.
Thank you. That's
Very
good
good.
work.
Senator Birdsall.
Just so there's no confusion, should the language, we're talking 1A, right? Where the department shall establish an administrative day rate for those days of hospital stay in which a client does not meet criteria, and then an appropriate placement outside the hospital. That's where you got confused. Is there some language that I want to make sure it's clear? We're talking neonate.
You have to spend some time with it, but I'm sure we could clarify it.
Okay.
I think it might just be deleting the or and replacing it with and.
That's a possibility too, yeah.
Okay.
All right. Senator Prentice, did you?
I was just, if I may, Chair Rochford, Senator Birdsall, I hear you, and I think it might be just the and, or not and, or it might be and, but the appropriate. So I mentioned during my opening remarks that I know of at least one, and now we're looking at a second. I don't want to call it facility, but like a home that is on, like located so close to a hospital that these moms would have no barrier to getting to the babies for eat, sleep, and console. And so that's part of it. If this is available to them and there's room, then they can, they should be able to go there. But we're really limited on that number right now. So that's why we're looking at the larger, can we take care of this on an inpatient basis? And it's only really 2 days versus 3 days too. So does that help with, because I think it does need clarity. I agree with you, but
I just want to make sure that no one else misreads this,
Yes.
and then somebody's in the hospital who's not in neonatal that tries to take advantage of additional hospital stay.
Okay.
That's all.
So I'll work with.
We're happy to work with you,
and
Senator
Director
Prentice.
Lippman, to tighten that up.
Absolutely.
Thank you.
Very good. Any further questions? Thank you very much. Hannah Martin. Oh, okay. Sure, if you could. Yeah, absolutely. Well, if you just want to just submit it and we'll get it. Yeah, that would be good. Yeah, that would be good. That would be fine.
The night shift last night.
Oh.
Taking care of delivery babies, but she's going back to do another night shift.
Hopefully you can get a few hours of sleep in there. You're young. I could never do that at this age.
Doctor, can you hand in the test?
Great. Thank you very much. Great. Thank you for coming in, and thank you for all you do. Thank you. Is there anyone else that'd like to speak on Senate Bill 137? With that, I'm going to close the hearing. We will be back here at 1 o'clock. So we've got about 43 minutes to grab something to eat, and we'll expect that fiscal note when you get back. It's just kidding.
That's gotta be an advantage not having it done.
Grab a bite. All right, Sophie, go get something to eat. I thought you were pointing at me. Very good. Thank you very much. We have Senator Pearl introduce his bill. Thank you. The shoe's on the other foot from this morning,
It is.
right? Yeah.
And I promise, I hope my bill won't take an hour.
All right. All right.
Well, good afternoon to the committee members. Great to be here. For the record, my name is Senator Howard Pearl from District 17. I reside in the town of Loudon, and I am here today to introduce Senate Bill 134. So we are a state that prides itself on work to support our families, independence, and self-sufficiency. Work requirements will help low-income families by offering them a way out of poverty. Medicaid and other welfare programs should be a bridge for non-aged, non-disabled adults, not a destination. Today, we have work requirements built into our food stamp and temporary aid for needy families programs. This should be no different because the policy is the same. Work helps families reach independence and is a core value in promoting health and wellness. Additionally, the Heritage Foundation has provided research of the hidden costs of staying on the Medicaid program, and that could be up to $323,000 in foregone lifetime wages for men and up to $212,000 in lost lifetime wages for women. Thus, encouraging low-income individuals to work more could significantly improve living standards. This taken together and along with other work requirements that currently exist in social programs improves health and welfare of our individuals. I want to be clear, the bill and the waiver that will proceed applies to those that are capable of working, and exemptions will be built into the waiver, like we have had in the past, that take into account any of the reasonable exemptions that should apply, such as where a single mom is caring for an infant child. So I want to offer you today that I brought a committee amendment. And essentially what the amendment does is it just requires that the waiver go before the fiscal committee for the general court for approval before it is submitted. So that way to make sure that the waiver that is putting in is what we all want to have, we want to see put in. So with that is my testimony introducing the bill, and I'm happy to take any questions, but I can tell you that John Stephen is here and he's going to testify for this as well. And I know he has a lot more technical info than I do on this.
All right. Very good. Any questions of Senator Pearl?
Senator Pearl. Good afternoon, Senator Pearl. I
Good
think
afternoon.
you maybe I keep calling him Commissioner Stephen because I knew him as my commissioner when I was at the Department of Safety, but Counselor Stephen may be able to answer this, but I want to hear about other states. Like I know that Arkansas has had a program, and I want to know, do we have enough data since these programs have been implemented to understand how it does really work and impact these individuals?
Sure. Thank you for the question. I'm really going to let Counselor Stephen, excuse me. Yes, it is.
It is Counselor, not
Counselor Stephen, not Commissioner. Former Commissioner Stephen. I'm going to let him answer that question because honestly, he has a lot of technical data on it and he will be a better resource than I am.
Thank you.
You're very welcome.
All right. Very good. Thank you very much.
Good with me. I'm going back to ED&A. We
All
still
right.
several
Have
more
fun
bills,
with that.
so thank you.
Yes. All right. Counselor Stephen.
Excuse me. I have a written testimony. My name is John Stephen, for the record. I'm going to submit it to the chair for the committee members right now, if it's okay.
You're fired.
Again, for the record, John Stephen, Executive Counselor, District 6, and former Commissioner of Health and Human Services in New Hampshire. Good afternoon, Mr. Chairman, members of the Senate Health and Human Service Committee. My name is John Stephen. As some of you may know, I'm former Commissioner, like I said, of Health and Human Services. It's so great to see Senator Prentice here, who has always done such a great job for our state, public service. I've run a consultancy for the last 15 years successfully in states, helped many states in understanding their health and human service environment. I'm here today, though, to support this legislation because work is fundamental to escaping poverty. In 2006, we passed welfare reform in the state, and I remember being the commissioner where we had really revised and upgraded our TANF program, and the caseloads went down more than 40%. It was a very tough bill to get through the legislature, but we tried to focus on work and community engagement, and it has been successful and it's been implemented ever since in New Hampshire, and we're one of the leaders nationally in the TANF program. There's no different here with Medicaid. There's currently no lack of jobs here in this state, and I want to also, as I say in the letter, and I'm not going to read it word for word, we're only talking in this bill about able-bodied individuals. I'll make that clear. This is not impacting the disabled. And those that are able to work, there are a number of exemptions that should be built into the waiver as well. And that's why I think that Senator Pearl is wanting to have the fiscal committee be involved in that review to make sure that the waiver has protections. So when we passed welfare reform, the first thing we did was travel across the state. We talked to staff, we talked to individuals, and realized that TANF, temporary aid to needy families, that is so important for you all as policymakers to know that that first letter T stands for temporary for a reason. And I do believe strongly that work is absolutely connected to health and quality of health. And I can tell you that I brought forward for you, and you'll have to make copies, is a research paper by just a couple years ago by the Assistant Secretary of Planning and Evaluation of the federal government. And in that paper, I want to just read, there's a section in page 8 that talks about the outcomes of work connected to health. And it basically says that in a study of societal health burdens and life expectancy, social and economic factors accounted for 2 of the 3 largest impacts on health and life expectancy. Poverty does impact health. We want to try to do everything we can to help people out of poverty and into self-sufficiency and independence. And that will also, again, help reduce their health, potential health occurrences, adverse occurrences, and improve outcomes and improve well-being. So I think in the last debate, and we can talk about the court cases, I've looked at all of them, there wasn't a lot of discussion on the connection between work and health. And there clearly is that connection. And I think if the Supreme Court would review this case, they would find that. But I have my testimony here. You can read it. I believe this legislation is really important to the state. And if we're talking about, helping individuals, to make sure that in a community engagement type waiver, that we're following the lead of some of these other states. So I think Senator Prentice's question is an excellent question. We've already have a waiver that we submitted back in 18, I believe, or 17. We already have a rollout of a very well thought out plan by the Department of Employment Security and the Department of Health and Human Services working together. There doesn't need to be a lot of recreation. There's going to be issues that we'll need to look at in terms of the technology and the staff to make sure that we don't have like an Arkansas problem, and I can answer any questions on that in the past. But this is a good bill. This is a bipartisan approach. It should be. And it's one that we all should embrace anytime we are trying to help individuals that are on Medicaid move from the Medicaid program to self-sufficiency. And especially with our low unemployment rate in New Hampshire, this is important, and it's a time where I believe this bill speaks volumes for those that are poor, low income, that don't have the opportunity. Because what you will find out, and what I've seen in other states when these types of programs are put in place, and I'm not suggesting the state agencies aren't working together now to the extent they could, but you're going to start seeing these state agencies work together very closely, very collaboratively, to make sure they provide whatever benefits they have to work engagement, skill building, development, having individuals in those communities that really need those programs, get those programs and increase access. So this bill doesn't really specify all of the provisions in the waiver. You can look at the past waiver. You can look at some of the current state waivers. Governor Huckabee Sanders is the most recent governor to submit the waiver, January 28th, 2025. I left the waiver here for your review, so you can look at what waivers what it looks like. It's a really good waiver. because it does take into consideration the prior problems they had in Arkansas with eligibility system issues. And I think that's something you have to watch closely. And I would want you to make sure you have fiscal committee approval so that both Democrats, Republicans on the fiscal committee can make sure the department is taking into consideration anyone that could fall through the cracks and not get the services that they need. So I'm here to support this bill, and I would ask you to pass this legislation. Be happy to answer any questions.
Any questions? Senator Prentice?
No.
No, good.
Council Stevens.
I just have some basic functionality questions of this. So we approve this legislation, and the legislation gets passed that's directing the department to submit the waiver. So the department defines the conditions and the criteria for the work program.
That is the way I understand it. That's the way it always is. Usually the department submits the waiver and defines that criteria. Several years ago, Senator, and I was here at the time, Representative Neil Kirk wanted to make sure that any waiver, and there was state law that was put in effect, and I don't think that state law is still applicable today, that any waiver, Section 1115, 1915B, whatever the waiver was at HHS, before it was submitted to the federal government, that it would have the approval of the fiscal committee. Okay. And that's what Representative Kirk wanted to make sure, to put that check and balance on the department's authority. I'm not sure that's still in state law. So they're going to need to get an amendment to the Granite Advantage waiver. It may be a whole new Section 1115. I'll let the department talk about that. But I think what Senator Pearl is trying to do is to make sure that that fiscal committee at least had some type of oversight and approval of the actual language. Let the department do what it does best. Look at the policy, come in and show you what the exemptions are, how it mirrors what other states are doing. And that would be in their work towards a waiver, rather than have you be so prescriptive and identify what the waiver has to say in every step. That's all. But again, it's your prerogative. You could outline, like the last piece of legislation, I think, had every single exemption in there. And there's a lot of states now coming together with these waivers, so it'd be good for the department to look at the language.
Sure. Thank you. Any other questions? That's it. Thank you very much.
Appreciate it.
Well, we're talking about the department. Let's hear from the department. Rob, Barry, David Chorney, and Karen Hebert. Welcome back. I feel like I've seen you guys before.
We brought Karen with us this time.
All right.
I think you guys need a new chair. This feels like it's about to fall apart.
We'll put it in the budget.
So good afternoon. My name is Rob Barry. I'm General Counsel to the Division of Medicaid, and with me is
David Chorney, the Deputy Medicaid Director.
I'm Karen Hebert, Director for the Division of Economic Stability.
So where to begin with this? So as you know, the waiver for the work requirement, or requiring a community engagement requirement for the Grant Advance program, was withdrawn back in 2021. At this moment, we feel there's a lot of uncertainty as to what the federal government is going to be requiring for any waivers going forward. So we are in a position where we're having a difficult time estimating the fiscal impact given the uncertainty. Criteria may change. There might be congressional action that takes it out of the waiver space. We don't know. There's a lot of work to come on this front. We also don't know how much of the infrastructure we've invested in already can be reutilized going forward. So we're estimating at this point about a $2.5 million general fund expenditure. With waiver in place, there is an ongoing evaluation requirement as well, which does cost some extra funds as well. And before I turn it over to David, I just want to let you guys know that we have here a July 1st, 2025 submission date for the waiver based on this legislation. We will not be able to make that if we have to go to fiscal committee and comply with all of the other federal requirements in the waiver as it stands right now. Right now, we have to have 2 public hearings and a 30-day comment period. And based on the way legislation is passed, I think July 1st is a bit ambitious. So just wanted to put that out there as well.
And I think on that point, that the timing of the submission of any waiver, I mean, I think it's reasonable to expect that this administration will put forth some guidance about what they would see as approvable in a work requirements waiver, or if there's congressional action that would allow a Medicaid agency to do it through a state plan amendment. And so the July 1st date wouldn't really be, if that guidance came out in, say, March, it would be not possible to incorporate it necessarily into the waiver approval. I can tell you for the waiver that was submitted previously, the cost that was spent was $4.4 million in total funds, and there was an additional $1.6 million for the evaluation costs that Rob had mentioned. And currently, only one state, Georgia, has work requirements. There are some other states that, like Arkansas, recently submitted a waiver for approval. There are other states that did, like New Hampshire, had an approved waiver, and either the Biden administration pulled it back or a court case held it up. But those states never went ahead with implementing it.
Yes. Thanks.
That's probably what's better.
Yeah. Good afternoon. I think it's afternoon. So I just wanted to first thank Councilor Stephen and his comments and support with respect to individuals who need the right support if there is going to be a work requirement. So my perspective of that, of course, is to ensure that we do have sufficient resources in order to stand up a program that may be similar to what TANF has in place with the New Hampshire Employment Program. I think there's data that could be looked at here with respect to the success of that particular program. There may be insufficient data to make that determination, but I think that again, making sure that we have the correct resources staff-wise to be able to support any kind of a work requirement for this particular program. Also, just really having the ability to conduct a bit of a risk assessment and making sure that we can identify really what is that particular resource that's needed to be able to provide you with the right estimate for cost of that.
Great. Any questions? Just have a quick question. So if July 1st isn't a date that can be made, what would a more suitable date be?
It's a good question. I don't have a date off the top of my head. I think part of it depends on what happens at the federal level in terms of guidance from the Trump administration. I'm thinking back towards other waivers we've done where there's been legislation that requires the waiver to go into, and I know there was one under HB2, and it was just over about I think a 13-month period from the passage of HB2 until when the department had to file the waiver.
Okay.
But I can follow up with some other examples.
Sure.
Yeah.
Any other questions from the committee? No, thank you very much.
July 2nd.
Yeah. Let's see, Michelle Lawrence. Good afternoon. Welcome.
My name is Michelle Lawrence, and I'm from Henniker, New Hampshire. I'm a volunteer with the Leukemia and Lymphoma Society. Today, I'm here to discuss SB 134. 15 and a half years ago, around my 31st birthday, I was diagnosed with a rare chronic cancer. Not a very fun birthday present. Happy birthday, cancer will cut your life short is not exactly a Hallmark card. At the time of my diagnosis, I was working as a case manager for a nonprofit organization and paid for private health insurance. At the time, my peers were planning weddings, purchasing their first homes, and having kids. I was left trying to wrap my mind around my cancer diagnosis and whether I would live. I had to quickly learn how to navigate the private health insurance sector while learning all about cancer. Both of these were challenges and stressful and time consuming, but I didn't want my surviving family to be left with any medical debt. I wanted to remain financially independent, which has meant making some tough decisions. People tell you life is priceless, but I beg to differ. It comes at a cost. As a single person supporting myself financially, most of my income went towards medical expenses. While paying for private health insurance for over 13 years, I spent approximately $20,000 just to walk into my oncologist's office. Copays, deductibles, and out-of-pocket costs add up quickly. And during those 13 years, I delayed treatment, I skipped doctor's appointments, and ignored doctor's recommendations due to costs. Sometimes I had to decide between going to the doctor's, paying rent, or purchasing groceries. Those aren't decisions a cancer patient or anyone should have to make. I am not living the American dream. I rent my place, I drive a 13-year-old car, and live paycheck to paycheck. Cancer is expensive and private insurance is just as costly. But we continue to tell each other that life is priceless, and if that's the case, then our actions have to start reflecting that. And that can start here today. 2 years ago, when my employer let me go, I couldn't afford COBRA while trying to meet my essential financial obligations. Applying for Medicaid was the only and best option I had, and I am so thankful I qualified. With Medicaid, I have had full access to all the medical care I need, including home health therapy and medication. For the first time in my cancer journey of almost 16 years, the primary focus is on my care and not my insurance and insurance costs. I no longer wake up in the middle of the night panicked because I don't know if I should skip the doctor's recommendation or pay rent late. Now I can seek the care that I need, follow up on recommendations, and I'm not concerned about raising medical debt. I don't have to worry about debt collectors or those notices in the mail either. Stress kills, we all know that, and access to Medicaid has alleviated so much stress, making me emotional just thinking about it, which is why I volunteered to share my story today, because I'm one of the lucky ones. I'm lucky because I qualified for Medicaid, even though I wasn't employed. I quickly learned that my cancer would no longer allow me to work full time. With my type of cancer, you can only slow it down going in and out of treatment. So that means that you take chemo, stop, recover, start again, and repeat. My new baseline didn't allow me to stand on my feet, work long days, or be alert during long meetings, or attend multiple sessions, etc. And deficits are difficult to admit, and I nearly died trying to hide them. But I also learned the hard way that looking for work was a full-time job as a cancer patient. I missed interviews and essential calls because I would fall asleep due to fatigue. Due to brain fog, I would forget about meetings and who said what when, and my doctor made it clear that if I kept working, the cancer would kill me quickly. The stress of employment was something my body couldn't endure. And what I'm concerned about, especially with this bill, is legislators defining when my treatment is considered treatment, when I'm recovered enough to work or not recovered enough to work, and adding more bureaucratic paperwork to the Medicaid process. It already takes hours just to apply for Medicaid. I can't imagine having to file additional paperwork every time I'm in and out of treatment to show that I'm able to work or not able to work. Without Medicaid, I would be dead. I'm a healthier person because I have the care I need and don't have to delay any treatment. In the state of New Hampshire, if the state of New Hampshire were to impose worker requirements, I would lose Medicaid. Working while undergoing treatment is too much for my body, and I know I'm not alone. Currently, 500,000 Americans are on Medicaid. Putting work requirements in place would create another barrier to healthcare and make it more difficult to access. Conservatively, statistics state that 1 in 3 people will be diagnosed with cancer in their lifetime. Sick people can't work. Sicker people die without health care. I could easily be one of them. And I am lucky, but luck shouldn't determine whether you have access to health care or not. Don't put a price tag on life if you want to see it as priceless. Vote no on SB 134.
Thank you very much. Is there any questions for Michelle? No, thank you for coming in today. We appreciate your words and your time.
Thank you.
Time for being here. Thank you.
Thank you.
Raymond Burke.
Get better at that.
Good afternoon. Thank you.
Good afternoon. Thank you, Mr. Chairman. For the record, my name is Raymond Burke. I'm an attorney at New Hampshire Legal Assistance, and I'm here today to provide testimony in opposition to SB 134. NHLA is a statewide nonprofit law firm. Our attorneys and paralegals represent low-income clients throughout the state regarding various civil legal issues, including on behalf of clients seeking to access health insurance through the different Medicaid programs. Based on our experience representing our low-income clients, we oppose this bill and encourage the committee to recommend the bill inexpedient to legislate. As you've heard a little bit already, Medicaid's main objective is to provide health coverage to people with low income. And we have significant concerns that adding a work requirement to the program will cause many people to lose access to critical health services, as we saw in Arkansas several years ago. I think Senator Prentice asked about Arkansas. They were the only one at the time to implement the waiver before courts struck down the waivers in Arkansas and other states. And what we saw there is that during the time it was the waiver was in place, 18,000 people lost coverage. And we didn't really see any significant impact on the ability to encourage employment or increase employment. A large majority of Medicaid beneficiaries who can work already do. Based on I think the most recent data that I've seen, which is prior to the pandemic, because the pandemic, of course, shifted things for Medicaid, 62% of adult Medicaid beneficiaries across the country who were not enrolled in Medicare and did not meet the Social Security disability criteria were either working or were in school. I think we agree with the Department of Health and Human Services that we believe this bill is premature given the timing. While there's been a lot of conversation going on about potential changes that might happen at the national level, our position respectfully is that nothing has changed since the litigation that challenged the prior work requirement. And so our position is that New Hampshire Department of Health and Human Services cannot implement a work requirement waiver under current law. And so, as I mentioned, all of the waivers, with the exception of Georgia, were struck down. And there are significant differences in the Georgia case versus all those other cases. And we would definitely appreciate the opportunity to talk more about that. But there's a few things that have stood out there. One, Georgia projected in the first year they would enroll 100,000 people. They only enrolled approximately 4,200 people. They also spent about $26 million, and 90% of that went to program administrative costs and not to costs for health services. And the key difference there's a lot more we could talk about, is prior to implementing the waiver, Georgia had not expanded Medicaid. And so that was a key factual difference for the court in that case that doesn't exist in New Hampshire. We already have granted advantage, and the key thrust of the case challenging the prior waiver that was successful was the risk of termination the risk of loss of coverage if the waiver went forward. And as you're likely aware, there are also a number of provisions of existing law that will be affected depending on what might happen at the federal level. So we're here respectfully suggesting that the most efficient use of New Hampshire resources and time is to respond specifically to those changes if and when they happen, similar to what the department was saying about, there's a number of different things Congress could do. There's a number of different things that the U.S. Department of Health and Human Services might put out with respect to what states will have to do this. And I do think if this were to go forward, there is in RSA 126-AA:2 that was never repealed. So there is still statutory language on the books about the community engagement and work requirements for granted advantage. Again, those didn't go forward because the courts didn't allow it, but that's still there. So if the landscape were to change, I think the general court would have to take a look at that and figure out what to do with that existing language that's in statute before the state were to move forward with a new waiver. There's more I could say about the importance of Medicaid that I'm happy to share if you have questions and who would be impacted by this. But in conclusion, we urge you to oppose this bill and very much appreciate your consideration of our testimony.
Great. Thank you. Any questions? Seeing none. Thank you very much.
Thank you.
Jay Couture.
Good afternoon. I'm Jay Kuchar. I'm the CEO of Seacoast Mental Health Center in Portsmouth, New Hampshire. And I'm here today representing the New Hampshire Community Behavioral Health Association, which is the association that represents the 10 community mental health centers in the state of New Hampshire. We serve collectively about 54,000 individuals each and every year. We are the backbone of the state's public mental health outpatient services. We are actively involved in services that help the state meet its requirement for the Community Mental Health Agreement and for the settlement agreement related to Mission Zero. We also work with our patients to help them achieve employment when that is a treatment goal and when it's appropriate. It's within our contracts that we do this. It is reported as part of the CMHA agreement because that's there as well. But it's not appropriate for everyone, or not everyone has the ability to work given the status of their illness. Arkansas has already been referenced, but that's a state where people who are living with mental illness, who one might have assumed on the surface would be exempt from the work requirement, found that they couldn't get that exemption. And so that is something I certainly worry about. I also worry about people who may lose their benefits inappropriately, which we saw happen with the Medicaid unwind. We had thousands of people who lost Medicaid, and a number of them shouldn't have. And the efforts continue even today to try to reinstate benefits in some of those cases. Following the Medicaid unwind in this state, the community mental health centers had a collective loss last year of $19 million. Further reduction in access to coverage for treatment, particularly treatment in which people are already engaged, which is what we experienced with the unwind. We are, by statute, RSA 135C, required to provide care without regard to ability to pay. So when you have people who have benefits, engage in treatment, and then lose them, that care continues. And that's really what fueled the deficits that we experienced last year. I absolutely believe that work can be a part of recovery. And you can see that in the state Phoenix reports that each center submits every single month. But I think that this bill is a mistake, that people would be harmed, and that the community mental health system would not be able to continue to absorb the loss of compensation for care that we provide to people in this state living with severe and persistent mental illness. So we are opposed to this legislation.
Great. Thank you very much. Any questions? Thank you. Thank you for all you do. I know that my communities really are grateful for the services that you provide in the North Country.
Thank you.
Jake Berry. We'll get you this time.
Sorry, I thought my handwriting was just really bad earlier.
That's all right. That's all right. I got you.
Good afternoon, Mr. Chairman, honorable members of the committee. My name is Jake Berry. I'm the Vice President of Policy at New Futures. As many of you know, New Futures is a nonpartisan, nonprofit health policy organization. We've been working for 25 years to help increase access to affordable health care in our state. We are here to strongly object to this bill as we fear that it would lead to a loss of coverage for many of the most vulnerable individuals and families of our state. But before I get to that, let me start with a point of agreement that we have with the bill sponsor and other supporters. Yes, we 100% agree that work is key to human dignity. It's also critical to the physical, social, and financial health of individuals. That's exactly why this program is designed the way it is, even without a work requirement. It is designed to provide short-term health insurance coverage to individuals to help them overcome periods of challenge in their life when they are going through a job transition, when they or a family member have experienced a medical emergency. This program is there to help provide them, what is hoped to be short-term health insurance coverage to regain stability, to be able to get back to work, and ultimately be able to move on to get health insurance elsewhere through employer-sponsored insurance or on the health exchange. And our churn rates on this program show that that's exactly the way that this is working. The program is meeting its goals. It is providing people the coverage they need to regain stability, to get back to work, and to move off of the program and get health insurance elsewhere. Over the lifetime of the program, there have been 252,000 individuals who have been enrolled in Medicaid expansion. There are currently about 59,000 individuals on the program right now. Again, this shows you the vast majority of people move on. As Attorney Burke stated, the vast majority of individuals on the program are working, are seeking employment elsewhere. Conversely, work requirements have been shown throughout the country to be incredibly costly and detrimental to our efforts to get people back to work and to meet the purposes of the program. In Georgia, as Attorney Burke mentioned, Georgia is currently the only state with a work requirement in place currently. There are 175,000 people who are eligible to be enrolled in the program. There are 5,100 people who are currently enrolled. 51 out of 175,000 people are currently accessing health care through Medicaid expansion. In Arkansas, when they tried to implement this program, in 2019, 17,000 people lost coverage, in part because they were unable to meet the administrative requirements of reporting, not because they were not working or not able to get back to work. In New Hampshire, when we tried to implement this program in 2018, a work requirement in 2018, once again, about 18,000 people lost coverage, were on pace to lose coverage before it was suspended. Meanwhile, the state was spending millions and millions of dollars to try and implement this requirement. As a side note, in Georgia, and I think that Attorney Burke alluded to this, where 5,100 people are currently enrolled, they have spent $26 million trying to implement the work requirement, again, leading to 5,100 people being enrolled. If you do the math, that's about $5,100 per person to implement the work requirement. So again, we see this work requirement as counterproductive to the aims of the program, counterproductive to getting people back to work, and would ultimately be fiscally irresponsible for taxpayers. So with that, we ask you to oppose this bill. And I'm happy to take questions.
Are there any questions? Seeing none, thank you very much.
Thank you.
All right.
And I'm sorry, I do have written testimony I'll hand around.
Sam Hawkins.
Good afternoon, Chairman, members of the committee. My name is Sam Hawkins. I'm the Public Policy Assistant at NAMI New Hampshire, the National Alliance on Mental Illness. NAMI New Hampshire is a nonprofit grassroots organization whose mission is to improve the lives of all people impacted by mental illness and suicide through support, education, and advocacy. On behalf of NAMI New Hampshire, I am here today in strong opposition of Senate Bill 134. You may be aware that Medicaid is the largest payer for mental health and substance use services in the country, providing coverage to more than 1 in 4 American adults who have a serious mental illness. As such, Granite Advantage, New Hampshire's Medicaid expansion program, provides crucial coverage for tens of thousands of Granite Staters and is an integral program for providing access to treatment for Granite Staters living with a mental health condition. We have serious concerns that enforcing these work requirements will have a grave impact on access to care without improving employment rates in the state. As you've heard a lot of people say, health supports employment, health supports recovery. We do not disagree with this, but it is critical to emphasize that Medicaid already goes a long way in supporting employment by providing access to treatment that enables people to work. We know that having a serious mental illness makes it harder to get employed and stay employed, but when people get the treatment they need, they can and usually will work. Further, as you've heard, research indicates that the majority of Medicaid enrollees are already working, and I have written testimony with specific data in that regard. You heard that about 62% of non-dual, non-SSI, non-elderly Medicaid adults were already working. You may then think that is 40% of people these work requirements may apply to. That is not the case. The rest of that number would largely qualify for exceptions, leaving just about 7% of Medicaid adults that these work requirements would apply to. However, you then think adding on to the burden of working, the burden of reporting, and the burden of the other challenging life situations these enrollees may be on, keeping up with those work requirements is just unreasonable, and it may discourage people from even pursuing coverage altogether. Now, that larger number that I mentioned may qualify for exceptions. As you've heard, in Arkansas, about 18,000 people lost coverage during the brief waiver implementation. Of those people, few people actually utilized the safeguards intended to protect coverage. They didn't make use of them. Can't exactly explain why, whether they weren't aware of them, they were too cumbersome, but people weren't using them. There was also a noted difficulty with reporting that presented barriers to people retaining coverage, and there's research indicating that enrollees in Arkansas were unaware of or confused by the work and reporting requirements, which just leads to no increased incentive to work. So with all of this in mind, individuals who would otherwise be able and willing to work due to economic pressures that we are all feeling, and thanks to the treatment that they're accessing through Medicaid, they may lose their coverage. It may lead to a worsening of their condition, and further increasing the likelihood that they will not be working, they will not be positively engaging with their community. So for these reasons, we really believe that enforcing work requirements is likely to decrease coverage, leading to adverse outcomes for individuals and families without actually improving employment or community engagement, and it will increase uncompensated care costs on the state, not just because there is less coverage, but because when people aren't accessing to care, their condition progresses, they're more likely to access emergency services, which have a higher cost. This is bad for people seeking care, this is bad for providers, and we just don't think this policy should go forward. So as such, we urge the committee to vote ITL for Senate Bill 134, and I thank you for your time.
Great, thank you. Any questions? Very good, thank you very much.
Thank you.
Anyone else that'd like to speak on Senate Bill 134? Yes, come on up.
Hello.
Hello, good afternoon.
Good afternoon. My name is Jules Good. I'm a Newmarket resident, and I am testifying in my capacity as the programs coordinator at the Autistic Self-Advocacy Network, which is a national disability rights organization focused on self-advocate-led policy advocacy. I'm here today to testify in strong opposition to SB 134. Any measure that makes it harder for people to access Medicaid services is a cut to Medicaid, and work requirements are no exception. A common misconception is that Medicaid recipients do not work. I know a lot of people were citing the 62% number as folks on Medicaid who do work, but a 2023 study from the Center on Budget and Policy Priorities actually gives us an even higher number, showing that 2 out of 3 Medicaid recipients nationwide do in fact have jobs. Imposing work requirements will not significantly increase the employment rates of Medicaid recipients, but what it will do is put unnecessary red tape and administrative burden between people and the healthcare services that they need to survive. Disabled people with high support needs who are unable to work or unable to work enough to satisfy the work requirement criteria will be unable to live in their homes without access to Medicaid waiver services. In addition, if their family caregivers are covered by Medicaid and are forced to work to stay insured, those caregivers will be unable to stay at home to care for their sick and disabled loved ones. And that ripple effect, when we consider Medicaid coverage for family members and family caregivers, the Center for Budget and Policy Priorities, in a study that just came out a couple of weeks ago, estimates that work requirements nationwide would put about 36 million people at risk of losing health care. Both of these factors, along with the unique impacts of New Hampshire's housing crisis on our community, all but assure that more disabled Granite Staters will be forced into institutions, which will in turn cost the state, patients, and their families more money, in addition to the increased administrative costs that others have mentioned this bill would incur. It's really a lose-lose-lose situation. It's important to note that the eligible community engagement activities outlined in the RSA this bill references will become even more difficult to access as programs like vocational rehabilitation see restrictions and funding cuts as a result of federal directives. This bill asks people who already struggle to get the care they need to jump through more hoops in exchange for fewer services. The hours of paperwork and extra appointments with providers that arise from the institution of work requirements would not only get the government more involved in people's everyday lives, but also raise program costs. As a former direct service provider for disabled adults on Medicaid in New Hampshire, I can tell you that the people receiving these services need them. They're not superfluous and they're not optional. The difference between being insured and being uninsured is the difference between life and death for people with significant healthcare needs. I urge you to vote ITL on this dangerous and wholly unnecessary bill, and I'm happy to take any questions.
Any questions? No. Thank you, Jules, for coming in.
Thank you.
Have a great afternoon.
You too.
Anyone else that would like to speak on Senate Bill 134? With that, I'm going to close the hearing. All right. Yeah.
I move to go into exec.
Motion, go into executive session.
Second?
Yeah.
We get a second? Okay, we'll be in executive session. So we won't be execing this bill today. We're gonna be, we're gonna work on some other stuff that we have pending here. So we will be back tomorrow at 10 o'clock. I'm sure DHHS will be right back here. You might as well pitch a tent, right? All right. So I wanted to have a discussion about that. And then I've got 3.
What does that look for?
Housekeeping.
We got this one.
You look pained.
I am a pain. What?
Immunization registry. You weren't here for that.
I wasn't here for that.
I don't think you're here for any of the ones we're gonna
Oh, okay.
talk about.
All right, well, glad to be part of it.
Yeah.
Certainly
I'm gonna
make
show you
yourself.
something now.
Huh?
I'm gonna show you something now.
I'm sure you made yourself familiar with the legislation, right, Kevin?
I'm very familiar.
We're gonna start with 75.
You looking for a motion on it?
Wait, hold on.
No, we'll wait till everyone's there.
Oh, yeah.
Providing health insurance carriers access to the state immunization registry and making an appropriation therefore. Oh,
Yes. Can they all be on at the same time, though?
I move interim study
I got a motion for interim study
on Senate Bill 75.
on Senate Bill 75,
Okay, I'll second the interim.
and we got a second. Senator Birdsell, do you want to speak to your motion?
Well, this is providing health insurance carriers access to the state immunization registry. It makes me nervous having anyone else. I mean, information gets out as it is. I'm just concerned giving additional people access to our vaccine, our immunization records. And in light of what happened at Dartmouth, even though they corrected it, it just makes me nervous. And I just don't feel that
Excuse me, what was that?
For an interim study, I'm pretty sure that can only be used in the second year session and first year.
That's news to us.
Yeah.
Really?
I think so. I just double checked.
Trisha?
Okay.
And I would move to kill it. To be honest with you.
So you want to,
I'll
Would
hold my interim study.
And I'll second that, and then I'll motion to
Well, the
listen to
we
somebody
can-
else.
senator.
we can talk. Senator
I'm
Prentice, did
focused
you-
on some madly trying, locating the bills. So a couple of things. I mean, yeah, I am a co-sponsor, but I want to, some of the things I heard during testimony for this, let me back my way into this. First of all,
Okay.
after, the fiscal note came out, I mean, I understand why the insurance carriers wanted to do this. But when the fiscal note came out and there was a cost to us, the state, to do this for the insurance carriers, I became concerned about that. Like, if this is something that you want, why, and I think there's still more cost, but this was like that $100,000 piece. So I was like, okay, I think I don't believe that we own that if we're providing access. You okay?
You have a fiscal note? I don't.
There was
There was discussion on a cost, I believe.
there's an appropriation.
Yeah.
Sorry, not a fiscal note, an appropriation.
Okay.
Forgive me. So I did bring this up to one of the carriers that was here in a side conversation that I just said, gee, like, we're being asked to pay for this. That was number one. Number two, I did confirm at the end. I asked, I believe this was former Senator Bragdon, who now represents Harvard Pilgrim. I asked him to come back up because at least two people who testified asserted, they talked about the vaccine registry, they talked about requirements, and they asserted that the health insurance companies would use this to make determinations on care. That they could, say, withhold care because this data was in their registry. And Peter Bragdon stated, for the record, I mean, we confirmed, number one, that it's an that being in the vaccine registry is optional. And that number two, they couldn't use the data they couldn't use this information to withhold for coverage for medical care. And so I understand some of the concerns that have been brought up and the weariness about data and sharing data, and especially when it's moving between one agency and another. And so I'm willing to pump the brakes on this for that only, but I just wanted to make sure folks were clear that it was being in the registry is optional, and that Harvard Pilgrim did say, and I recognize what you are raising, Senator Birdsall, about the concerns that came about COVID vaccinations and DH, which has been resolved, but I understand how that, came into this. So not required to be in the registry. An insurance carrier sat here and said, we won't use it to make medical decisions. I don't think we should be paying for this. And and again, I'm a co-sponsor, so I'm like, ugh. And I'm concerned about the security of any data that's moving around right now. So I'm going to stop there. Thank you.
All right. Thank you.
I'll move on inexpedient to legislate.
I'll second.
So we got a motion, ITL. Second.
Since we can't interim study.
Thank you,
We
Trisha.
can't interrupt.
You know
Can't we
you're watching.
re-refer?
Yeah, we can re-refer, but why?
then we-
Why would
we
we
can-
re-refer?
on it?
We're gonna get it
Oh,
back. Yeah.
okay.
Yeah.
Just
Let's kill it.
Yeah. And, I just want to also point out that in the testimony that really struck me is it wasn't a public health issue. The reason for doing
It was
this wasn't
accreditation.
to improve public health. It was to assist an insurance company in achieving their accreditation scores. And that's not, I have a lot of reservations for that, and I will be voting ITL. So, anyone else, anything else to say on this? All those, do we do roll call, or do we just, all those, I can't. All those, all right, all those in favor, raise your right hand.
ITL?
Yeah,
Aye.
aye. So, are you?
And I'm going to vote again. Yeah, I'm going to.
All right.
I'm a sponsor of the bill. I put my reservations on the record. I'm okay.
All right,
There we are. We're all good.
all right, ITL 5-0.
No, 4-1.
Oh, we had, we did one, okay, 4-1.
Can we still consent with 4-1?
Yeah. Do you want, Would you mind it going on consent?
Roll it on consent. Yes, move to consent. Move to
Second
put on
that.
consent.
All right, we got a motion and a second to consent. All those in favor say aye for
Aye.
consent. Aye.
I'll take it out.
Opposed? No. So,
For the calendar, I believe, they're gonna try to send it out as early as possible tomorrow because of the storm. So I think because this one doesn't have an amendment, we could probably put it on there, but for anything we do, sort of, it's gonna be a fast turnaround. We can get it tomorrow.
We don't have session tomorrow, though, do we?
No, we have hearing. We're here.
Talk about for next week, because it's gotta be in the calendar for tomorrow, by
Oh, I
noon
see,
time
yeah.
tomorrow.
Good job.
all right. Senate Bill 75. Cross
what
that
we-
one off the
Oh,
list.
I'm like, we just did that one, didn't we?
No, yeah, closing that out. The next one I have is Senate Bill 121 requiring notice to the insurance department of the discontinuance of certain types of insurance, including Medicare Advantage plans. Okay,
I do too.
did everyone get the amendment? If not, we can send that out.
It was from, it's not like official from all of them.
I don't have it.
I have a copy.
Maybe I have it and I wrote.
Yeah, I don't have
I
it
have
either.
copies for everyone.
Right.
Well,
I'll take one.
I just gave Senator
Three.
Prentice one.
Thank you.
Three, how did I get three?
So do you need a motion first?
Well, let them,
Let's get the amendment
Yeah,
out.
I remember the discussion about the amendment. Hang on a
down.
second.
You can't have an amendment until you have an emotion.
Yeah, we have a motion and we'll get
let
the
them read it at least.
Oh. You can't
Thank you,
submit
Senator Bertzel.
You can't submit the,
Would you like to make a motion?
I'm about to pass.
All right, we got a motion on to pass. We have a second.
Second.
All right.
Oh my God.
We have
There's an amendment.
Yes.
Amazing, little brothers, really.
I know, right?
And this was presented by Department of Insurance?
Yes.
Right.
Well, this is your bill.
Yeah.
Yeah,
I was sick. So.
I know. I know.
So they put back in fire and casualty.
Wow.
Transact fire or casualty business in the state shall provide 100. I guess they want to include if they're going to cancel any fire and insurance.
Like they did in California?
We won't
Just
talk
saying.
about that. To the insurance department is to. Okay. Yep.
Oh, and that significantly modifies is that was a
Oh, she's gonna yell at us.
one note I had is the 90 days is this the takes effect. Oh no, forget it. No, I'm good.
Yeah, I had that same.
Yep.
It's 90 or
looking to
120.
90 or 120 and
They're saying 120.
right.
So we were looking at changing it to 90.
Didn't Paula Rogers bring up that there was a federal preemption that had to do with the 90 days?
Right. Yeah, that's what I got.
Here it is right here. Paula Rogers, Mrs. Rogers stated that she had a concern regarding the 120-day notice currently listed in the bill. She asked if the committee consider implementing a 90-day notice for regulatory purposes because that is what is currently used at the federal level.
Is this going to finance? What is there?
We could, this is a fiscal
It does have a
note,
fiscal note,
but
but it says, yeah.
What?
No one has it in their mind already.
Oh.
no fiscal impact.
Oh.
So there's
All
no,
right,
so we can
actually
waive that.
This can be waived, actually.
All right, and make a note of that.
Was there a reason why they said 90, 120?
You want to change it back to 90?
Hold on. While the standard notice period is 90 days at the federal level, this bill is using a 120-day notice to keep it consistent with New Hampshire
Right.
statute.
So New Hampshire is 120 days.
Yeah.
Okay.
That's why they went with the 120, because that's consistent with New Hampshire's.
Which I totally understand. I just have this distinct, although it's not, this is not a criticism of the hearing report. It's not reflected this way. I thought that Paula Rogers said that the federal 90 days like trumped, pardon the pun, the 120 days. Like it preempted.
Well, if it's all in our statutes, then I don't know if they wanted to, if the feds wanted to review that, they would have before, and we would have had to change it, I would think.
That makes sense to me.
Yeah, the feds are at 90 days, but I don't believe they'd have an issue with 120 days.
Okay.
Because that's consistent with what we have.
Yeah.
State, yeah.
All right.
They would have brought
Okay, I
it up
just-
long before this, I think.
She was the last person to speak, and you know, Paula Rogers has been she's been around for she's
a pillar.
Yep. So although I haven't had the opportunity to work with her for more than like half of a session, she gets my attention pretty quickly. Okay, I can do that. That's fine.
So are you moving the amendment?
I'll move the
Senator
amendment.
Prentice? Okay.
So yeah.
And Senator Avard seconds the amendment. All those in favor of the committee amendment to Senate Bill 121, say aye.
Aye.
Any opposition?
Move on to pass as amended.
Yep, so we've got to move ought to pass as amended. We've got a
Second.
motion and a
OTPA.
second. Were you that's the motion. That's the Senator Prentice is the second. All those in favor say aye.
Aye.
I have a motion to put on consent.
Consent.
Second.
So we've got Senator Avard, motion to consent, Senator Birdsell, second. If we're going too fast, let me know, Sophie. All right, all those in favor say aye.
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 All right. All right, Senate Bill 121 is done.
I will.
Oh, yeah, Senator Avard can take that out. And then who did we decide on 75? Who's taking that? Senator Birdsell? Okay. You gotta forget about these things here. It's different in the House.
I see, I'm right here. I could just tell her I'll take it out.
All right.
Ray told me to behave.
Senator,
I know.
Yeah.
She told me that too.
Senate Bill 123, this is requiring coverage of ear acupuncture as a treatment for substance misuse under the state Medicaid plan.
Do we have a cost for that yet?
Not quite.
Thank you, Rob.
Previous when I put together, I overestimated the cost of what the treatment would be based on regular acupuncture. Significantly overestimated the cost. So I do need to file an updated fiscal number.
You want to wait for that?
Yeah.
All right, we'll wait on that.
I can prioritize get it by next week.
Okay, we'll wait on that.
Everything is a priority,
Suzanne?
Rob.
Senator Prentice, are you okay with that?
Yeah, I am. Thank you, Senator Birdsell. I am okay with that.
Senator Prentice, on Senate Bill 137, your bill for hospital stays.
Did you get language for that?
Yeah, do you have a committee amendment you want to put forward on that, or?
Give me just a slick second.
Yep.
'Cause I might be able to. And Rob, pay close attention here.
137, we just did that. That's the hospital coverage for
Newborns,
newborns on
prenatal.
drugs.
Yeah.
Now, just for the sake of discussion.
Yep.
Should we make a motion?
Okay, so I'll make a motion of OTP for Senate Bill 137.
Second.
Okay. So for sake of discussion, so section 1, number 1, is the question that has come up is the appropriate placement outside the hospital is not available, like for criteria, and the Department of Health and Human Services said, well, gee, that means everybody. But then as they heard number 2, which was postpartum parent with the neonate in the hospital being cared for because of exposure to to opioids while they were in utero, there's a definition there for postpartum parent. So the question about number one is that just needs to be slimmed back to say an appropriate placement outside the hospital for a postpartum parent that's not available, or
I think it's tying the two conditions together. One, there's not an available placement outside the hospital, and there's a neonate admitted to the hospital still getting it.
So
just for clear. Oh, go ahead.
So I think what they're alluding to is where you say an appropriate placement outside the hospital is not available and the postpartum, so they're connected.
So I'm fine with that. I just, the language, maybe as it was initially discussed being so broad, I didn't know if we still had to tie in postpartum to number one, but your position on this is that if it's an and, then it clarifies, and there will be no question about the one connection to two.
Yeah, the and makes it conjunctive, so we have to have 1 plus 2, and the way you had it is either 1 or 2.
Okay. Go ahead.
Yeah, I just have a question. So you had a figure of 100 people, blah, blah, blah. Is that going to be whittled down to like 10 or 15?
But we'll have to go back and do some work. It's going to go down.
So
I think it's like
this is going to go to fiscal.
I hadn't.
Yeah.
It is going to go to fiscal. I had an estimate somewhere of maybe 40K. This was in a conversation with a hospital, an advocate that does work in this area, that it could be 40 a year, it could be 18 a year. Like we don't have an exact number, but it sounds like it hasn't exceeded 40. And also, I just think for purposes of clarity, this could, like I brought, it could happen anywhere in the state.
Right. So like under 50 for sure.
So I would say, oh, come on up.
Okay.
We like when you come up here.
So I would say we should have the fiscal note by the time it gets to finance, and then we'll deal with it when it comes to finance. So we won't have the number, so I'll try and make sure that Jim doesn't waive it, just so we know what we're dealing with.
Yeah.
Policy purposes.
Yeah.
So the policy goes, the finance part is going to be worked. Okay.
Sorry, I just have a quick question. I'm sorry. So you were saying 40 individuals a day
No,
Per year.
per year.
per year?
Yeah.
Oh, okay. Per year, and do we have a cost average?
No, this was like,
$180.
I was asking outside of,
Go.
say, the largest hospital in the state, if we estimated everywhere, what could that number look like?
Okay.
And this was totally ballparked. So there's no science involved in this. This is just like,
That's how I have to work sometimes.
so we're going to have to work it backwards from, is it 40? Is it someplace else? I'm just wondering if there's a specific discharge code that you can use.
We can look into it.
Yeah, that it's gotta, like, maybe it has to do with looking specifically at not the moms, but the babies, the neonates that are getting, any type of care. They could potentially be getting medication too.
Okay.
So I think we need to look at those babies.
Okay, we can do that. So the fiscal note I put together is in process, so it might actually make it before I have a chance to update it.
Which would
So
be
when
frightening,
you
yeah.
so when you see it, just ignore it.
Okay.
So you did,
Well, that'll give us an incentive to get it to finance.
you did mention $180 a day for something.
That was our swing bed rate. So we were tying it to the swing bed rate. I don't know if that's even appropriate anymore because so that's where I can keep it at 180.
No, I was just curious.
And
Yeah.
let's the other thing, if I may confirm, it's, as I heard it from Dr. Lee, typically these moms are there with their babies for up to 3 days. And so this would be an extension. If 5 is where the science says they're good to go, then it's really 2 days. So we're not paying there's already paying for 3. It's the addition of the 2.
Right.
Yeah. It would essentially be the difference between when they're discharged and getting to that 5 days. So on average, if it 2.5, 3 days. And I was just looking at some data for 2024, or is 2023 or 2024, the number of births in New Hampshire total where the infant was exposed to opioids pre-pregnancy or pre-birth, it was around 430, and that's all births within New Hampshire. So this would be a subset of that, where the child is still in the NICU, and then a subset of that where they're on Medicaid. So I think we are talking about pretty low numbers when it's just limited to the postpartum mom with a NAS baby in the NICU.
So will your fiscal note also address the cost of if the newborn had to go into a NICU for that period of time to show the cost savings?
Yeah, to essentially, if we find or we can show that there is the potential to defray NICU costs because the baby would be able to be discharged earlier, that'll certainly be included in our analysis.
Okay.
All right, very good. So we've got a motion and a second. Do you want to put the amendment, your committee amendment in for changing that word?
The order end.
Sophie can do the
Yep.
committee amendment.
Okay, so do I have a motion on committee amendment?
Yeah. So Senator Avard wants to make a motion to, on line 8, number 1, to take the last word of or out and put and.
Yeah.
And I'll second his motion.
Any further discussion on that amendment? All those in favor say aye.
Aye.
Opposed? So the motion now is we've got an auto pass motion and a second. Any further discussion on the bill? All those in favor say aye.
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 Opposed?
Thanks, everyone.
Motion to go on consent?
Sure.
Got Senator Avard's.
And I'll do the blurb.
Okay. Oh, I'll say,
second.
Senator Prentice has got the second. All those in favor say aye.
Aye.
Aye. And Senator Prentice will take it out.
I will. Thank you.
All right.
My phone's recording us.
Oh.
I'm glad you're back. I was looking for you last week. I was like, where's Senator Avard?
I'm here.
Well, you were unwell.
I still got a little bit of it.
All right. I'm not going to take a motion on this bill, but I kind of wanted to see where everybody's at on Senate Bill 120, the relative to insurance coverage for biomarker testing. Anyone have any thoughts on that?
I'm just really nervous.
I have a revised fiscal note that I'll test out.
Oh, on that bill?
It came out, yeah.
I think
Okay.
I might have it. 121?
120, right? The biomarker.
Yeah, I got it. Okay.
You weren't here. Oh, Innes.
Sure.
Yeah, I talked to Dan about this. I'm just really nervous when they start putting biomarkers in, and are they gonna look at our, if someone has if we're requiring health insurance coverage for biomarker testing, and I know it's probably a little far-fetched, but are the insurance companies or even the life insurance companies going to take a look at this and see, oh, you have a preponderance or potential of having cancer down the road, we're not going to cover you? That scares.
I understand why it scares you. Did
Makes me
we talk? Yeah. Did we talk about that?
I think I asked that question, and
I don't think, could we, so two things, may I, Senator Birdsall, Chair Rocheford and Senator Birdsall. I think, one is that we could put language specifically in there that says this.
I agree.
That memorializes you can't use this to not authorize care. That's not what it's there for. And then the second thing is, and I don't have that file with me, but we got a pretty robust list of states and that do fund biomarker testing. Amazingly, a number of them, Medicaid programs do, and not all of them were exactly the same. And so we might not be ready for prime time, but is it appropriate? And I'd want to talk to the sponsor of the bill and some of the advocates to be specific about some of the biomarkers. Is that, or would that become limiting? So that was the only other thing.
I agree with you. Senator Birdsall brings up a very good point. The last thing you want to do is find out you've been canceled because you thought you were doing something to protect your health, and all of a sudden now you're out of luck. that's the thought I had.
Yeah,
is,
like a-
is prohibiting that.
Prohibiting a discrimination clause, yeah.
Exactly. You know, I think you're right. Looking at was like 15, 18 states do something like this. I mean, I see the benefit of it. You know, with my background, I see the benefit of it, and I see, you know, we talk about the silver bullet drugs. Well, this is how you get the silver bullet drugs. You test and see if drugs work, and,
really start
and
to-
see if therapy works. So I see the utility and the value in this if we can protect people from being discriminated against.
Yeah.
But to your point, what's that?
Go ahead.
I know, set of words, it sounds familiar to me, like, you just, I heard this.
Yeah, I couldn't find it. Prohibiting, I'd still be a little scared of that because I'm still gonna know.
Mm.
You know what I mean?
Yeah.
So articulating, I don't know if I don't
Maybe
know, if looking at the other states, if we could articulate what it would be used for.
Maybe it's not a prohibition or a discrimination, but it's a statement of the exact purpose for the use of this. I know that sounds like, oh, don't we already know that? But it can't be used in any other way but for the purposes of testing for therapeutic, or, you know, just for therapy, you know, for targeting to, you know, therapeutic, their modalities, therapeutic care. I mean, there might be someone in the room who can kind of sort of help us talk through this. I know we're not close to getting there, but we're not close to voting on this today. But I think that instead of, okay, I'll dial back my prohibition language and say maybe if the purpose language is more targeted, we could avoid that concern.
And is it okay. Okay, so it's just requiring insurance coverage for biomarker testing. So the individual doesn't have to have it done if they don't want to.
No.
Right.
Correct.
I wouldn't.
It's as if they availed themselves. We had somebody testify who availed themselves of it because they were diagnosed. They were diagnosed with cancer and they were trying to narrow it down.
Like a right to try type of thing?
No, right. It wasn't right to try.
Right to try is law, yeah. That's a little different.
Well, all the insurance providers are against it.
So Paula Rogers did say that section 1 is a bride. So I think she was, because biomarker testing legislation has erupted in last, is around for. Yeah, section 1 is broad. There should be a distinct set of biomarker testing causing the issues here. What were the issues that we heard? I didn't hear this broad-based issues of biomarker testing requirements. It was specific. I mean, I heard cancers.
I think Alzheimer's. There's an Alzheimer group that
Alzheimer's.
came. Yeah.
More than just that too.
Said Ms. Rogers noted that a mandate study was just completed in Massachusetts. I wonder if we can get our hands on that.
I'll email her.
Yeah.
Okay.
I think a very helpful advocate in the audience might be able to.
I forgot.
Has access to this and could.
Absolutely. Come on up.
Do you need my glasses?
Mike Rolo from the American Cancer Society, Cancer Action Network. I don't have anything prepared for you today, but yes, we can certainly get you a copy of the report from Massachusetts. I think, though, that just so there's no confusion, this is not a genetic test. This is just a test, a biomarker test in instance of cancer, which is my world. You're taking a specimen from most times a tumor, sometimes it's blood, to determine exactly where Senator Rochefort said. I think it was Senator Rochefort, maybe Senator Prentice said it. Determining the best treatment option for that particular form of cancer in that particular tumor. So I don't think, I understand your concern, Senator, and we would we've been asked to support legislation in previous years that we had the same kind of, not this issue, but similar to what you're bringing up, and we would not support it because of some of those issues. However, I mean, there's the pre-existing condition clause under the federal law, so I don't think really that this would, but I understand your concerns, but this is not genetic testing. This is specific to the illness. So you're not searching like widespread to find out if someone, and it's sort of cancer anyways, the person already knows they have cancer and what's the best treatment option. And then conversely, they can do this testing to find out whether or not the treatment actually has worked. That's a little different. Now for Alzheimer's, I'm not an expert on that. I don't know all the ins and outs. I know they wouldn't be supporting this though, because I've had this conversation with them, if they thought that it would interfere with their folks getting access to health care. So that would be what would happen if they didn't get the insurance. So, but I'm happy to provide any additional information. I know, so on the one pager we gave you, there was a list of organizations on the back, like the Michael J. Fox Foundation. So there's now a biomarker for Parkinson's. There's for Alzheimer's, cancers, but it's not for all cancers, right? I mentioned that in our testimony, and I know it's not for all types of diagnosis for folks with the other chronic diseases. Arthritis is one of them. So it's, I know the carriers, and I'm trying not to retestify, but just to respond to some of the questions I've heard, that they claim it's very broad. But, you know, I've been hearing this about every single coverage bill that I've ever, and not only my issues, I've sat in this committee room and upstairs with the Cancer Society now for 14 years, and every time there's a mandated coverage bill comes in, the sky's going to fall. So I might dial it back just a little bit on this one. 20 other states have done this, and if you look at the list, I mean, Texas, Louisiana, I'm actually looking at Senator Birdsall has it up in front of, I think, right in front of me so I can see it. I mean, California and Texas don't usually agree on a lot, in Louisiana and New York State, but they have passed this, Arizona, and there are active bills in all of the northern New England states as well, not just New Hampshire. It's going on in Vermont and in Maine as well. So it's...
Do we know, do we have any,
That's the list.
any information if on the states that passed it, has the premiums gone up? They always go up. But...
Well, I was just going to say, I mean, I've never, in all the years I've been having health insurance as an adult, not seen my premiums go up. But that being said, in the states that have passed it so far, we have not seen an increase due to this.
Okay.
So, and you will notice on that list, Senator, that, and I think you might have someone mentioned it, and I was busy trying to take notes in my mind, at least, so I wouldn't forget. But some states have done this for Medicaid only, like Connecticut just passed it last year, only for Medicaid. And this year they're going to do commercial. They're working on commercial this year. It's the insurance capital of the world. So, I mean, it's, you know, a little different. But, you know, some states, Arizona did it, I believe, only for commercial. They excluded Medicaid. You know, so it goes back and forth. Illinois was the first state to do it, and they did it for everyone.
Arizona Medicaid is included.
I didn't hear what you said, Senator.
I said Arizona Medicaid was included.
Okay, so I might have that state mixed.
No, it's okay. You can get one or two wrong, but
I try. No, I try not to, but they, I know in Medicaid, Arizona did something different though, that than all the other states, and now I'm
Medicaid's included.
I don't remember.
Diseases all covered.
Okay, but there were
Screening explicitly excluded.
say that again.
The screening was excluded.
Oh, okay. Maybe that was it then. I don't know.
And if I may, I just want to add that, you know, I was chatting over here with Senator Avard about the list and the Medicaid coverage to me. And I think it might have been Senator Birdsall. We talked about this like when we saw this list, and what it further affirms for me is that Medicaid has seen the value of being able to make identifications and tailor treatments and be able to, I know, but it does drop costs. I mean, I've heard
well, that's the point, yeah.
I mean, it's better for the patient, and it also is going to be more cost effective or efficient. So if Medicaid seems to be leading on this
In some places,
and
yeah.
that's like, whoa, I think that's
Yeah.
That
and-
says something.
And it's after, during, and before, and during, and then after the testimony, was it just last week, I guess? I had an opportunity to speak with the folks from the Medicaid office, and we're in full support of, they had suggested some language change on clinical utility, and we're fine with that. That's what they did in Iowa. And I don't remember, I don't have it in front of me, I'm sorry. But we were fine with that. And we actually offered a definition because it might be beneficial if you're going to use the term clinical utility to actually say what it is. So we provided a definition to them. And there were folks from the carriers that were concerned, again, that was too broad. We would suggest putting clinical utility up in the commercial side too, not just for the Medicaid side. So if that would alleviate some of their concerns that they think doctors are casting a net trying to
Let's just
use.
randomly do this test. No.
Right, yeah, which, yeah, I don't think anyone really believes
No,
that's
but
happening.
I think that was
Yeah.
the assertion is that it could be used in a more like concierge way
Right.
versus a necessary way.
Right. And I was trying to be clear in our testimony that we do not want to see that happen. We want the judicious use of this testing. We don't want it. It's not for everybody. We know that. So, but we trust oncologists in the state.
So where would that
So
go?
it seems like with cancer, we already identified the cancer, and this will give you the best treatment for
Yeah.
that typical person's
Yeah.
treatment.
Right.
And then the only thing would be the woman that testified, Miss Dennis, testified that she was forgetting, and it took her 2 years.
Alzheimer's, yeah.
She spent $8,500 to have this done. So Alzheimer's would be looking for in your genes, I would guess, or however, to see if you're apt to have Alzheimer's. Right? And that
Yeah.
was the so as far as Alzheimer's go or dementia, it would be
You already have the condition.
you have the conditions and you're
Right.
likely
Right.
to, okay.
We could save money. Why are the insurance companies doesn't make sense to me.
So the question is, so on page 1, Roman number 2 on line 29, it says, biomarker testing shall be covered for the purposes of diagnosis, treatment, appropriate management, or ongoing monitoring of an enrollee's disease or condition when the test is supported by medical and scientific evidence. What is so broad about that?
But not limited to.
Not limited to label indications for an FDA indicated tests.
So we could, I mean, I don't like the term, but not limited to. I mean, that's,
Well, I think
Well,
if there's some language that we can tighten it up, I'd be willing to support it.
Yeah, I want to support it, and if there's language that will, make my colleagues feel more comfortable that we're getting, we're just focused.
Here comes Mike.
Well, is that where the clinical utility piece can come in to help alleviate some of your concerns? I mean, I'm happy to,
Can you,
I know that you all were going to, I don't want to speak for the department. I'm above my pay grade, so I'm not going to.
Yeah, at least from the Medicaid perspective. So we do cover biomarker testing. It's on a one-off basis right now. We look at the biomarker test, but there's this aspect of clinical value or clinical utility that our medical director goes through in, trying to really ensure that the testing will inform the treatment and diagnosis that the patient will get. And in some cases, when you look at some of these really expensive therapies that could be available, the biomarker testing is absolutely essential to making sure that that testing that you're, or the therapy that you're to spend a couple $1 million on will actually potentially work, right? And so without the biomarker testing, it doesn't really make much sense to not cover biomarker testing, but to cover. So that we cover biomarker testing in that avenue. And so it's just incorporating the clinical value and the clinical utility aspect of assessing the biomarker test to make sure that, one, it is medically and scientifically approved and will provide treatment and clinical value to the patient. the results of the testing will provide clinical value and treatment to the patient.
Why would the insurance companies then not do the same?
Well, that's not.
Some of them are, Senator. So I think that's what was sort of lost at the hearing. And we were at towards the end of the day and we were limited on time, but they may do an individual panel, but they might not do a full panel that would actually tell you the full story of what's going to best be suited for this patient in their journey through whatever disease it is. So, I mean, they are accurate when they come in and they say, well, we already cover biomarker testing. Well, they may cover a certain aspect of it, but they're not doing the full coverage of biomarker testing, which ultimately I think you all recognize that it's $8,500 was one of our volunteers talking about her test. I can only imagine how many hundreds of thousands of dollars the carriers would have had to cover if they had gone the different route and she had to have the surgery and everything else. I mean, so of course there's a cost savings.
I'm sorry.
No, I'm sorry. I shouldn't be testifying. I should.
So is there some language that can be drafted to tighten it up that would, okay.
I most certainly, and we're more than willing to work with the department and anyone else. And I've told the carriers too, I spoke with them out in the hallway that we want to work with you. We don't ever want to, believe it or not, we do partner with them every once in a while. We do. I mean, and we partner with hospitals and everyone else. I mean, whoever's going to help patients, we will partner with them. So I would like to get their input too. I mean, it shouldn't be done in a vacuum.
If you can work and get some language, that would be helpful.
Yeah.
And we can try and get it through.
Okay, I appreciate that. Thank you.
If I can, Mr. Chairman, does that language remove not limited to? Do you know, or would that still be in here?
He doesn't have the bill.
Do you mind if I just look?
And he can't read it.
Wow. That's Senator Long did me a favor. You wrote it in red, so I can actually. That was the
long arm of the law.
It's all FDA.
I think we could put in terms like clinical utility that would give that a little more guidance with that, which you're going to do anyway. I mean, that's what you're doing anyway. I don't see what this does that's going to change any of your practices right now.
And we would be 100% in favor of that. We, like I said, we want to make sure it's the.
Think you guys can get that to us next week?
I want to speak for you. I mean.
All right. Very good. We'll be here next Monday and Wednesday, but we'll give you till Wednesday.
So I have the distinct pleasure of doing this in New Hampshire, where I was born and raised, and I love more than anything. But I also cover the lovely state of Vermont now, and I have to be in Vermont to talk about this very same subject.
If you can get
10
the
in the
language
morning,
to
so I
us,
won't.
that's fine.
Okay, so I won't be able to be here to
No.
help with anything because I have to do the
you
same
get
thing.
it,
over
and we may
there,
not
so-
we may not take it up, but if we can at least have it to consider it, that would be great. Yeah, it is upside down.
Up my front window.
It's upside down.
And then the Massachusetts study that we talked about, if you could get that to Sophie, that would be great too. Yep. Very good. Anything else that we want to cover before we head out of here today? All right. With that, I will close the executive session. Oh, we have to have a motion for that?
Yeah.
All right.
So Senator Avar made a motion to move out of executive session. I seconded that.
All those in favor say aye.
Aye.
All right, we're out of executive session. So tomorrow, 10 o'clock, and then we'll be here Monday because we're getting swamped here, but we will be here Monday as well.
I don't know if I'll be able to be here on Monday. I am.
What time
I am
Monday do you
full.
10 o'clock on Monday. 10:15.
Yeah, I'm already booked out. I
Yep.
booked my work days.
I'm generally booked.
Well, I will be here
And you
Yeah, I'll be here.
can.
because I do not want to be here the last week of February. So
I understand that.
we'll
I mean, I might, if I can, I'll have to kind of run in and out of.
Sure.
things. Yeah. I can
That's
do
the
that.
10th, right?
I can do that.
good.
Yes.
All right, we're gavelled out. Thank you.
So I may be a little, I think I got an appointment tomorrow. I'll be leaving Manchester probably about 9:30, so
Okay.
I should,
You'll be here at 10. So
yeah, 10, a little after.
we'll get
whatever.
started at 10 and Yeah.
Keep in mind, probably by 10,